Good morning, everyone, and it's with great pleasure we welcome you all for the day two for this webinar on management of breast cancer in new millennium, the clinical updates from SABCS. As we all thought about that we don't want to disturb your Valentine, but of course we'll take some time for your Sunday. It's a pleasure to welcome Dr. Vikas Thalreja. He's a consultant medical oncologist at Regency Hospital, Kanpur, and the co-organizing chair for this event. So without much ado, it's a pleasure to welcome Dr. Vikas for your welcome introduction and start the proceedings, please. Over to you, sir.
Thank you. A very good morning on a sunny Sunday. And I would say that it was enormous success. The first day we had more than 700 registrations, more than 350 attendance. We are running 3 parallel workshops right now, and it gives me an immense pleasure that this event has built up its reputation like the last year, the best of SABCS 2021, and we are looking forward for a highly academic, interactive, and rewarding session for today. May I have the honor of inviting to the first session, which is in hormone positive, HER2 negative breast cancers. The chairpersons for whom are Dr. G.S. Chaudhary, who is well-renowned consultant medical oncologist, West Command Hospital, Faridabad, and Dr. S.H. Advani, sir, the director and head of department medical oncology at Jaslok Hospital. Both are emirates in the field of medical oncology and needs no further introduction. I won't take further of your time. Wish more and more interactions and discussions and intellectually rewarding session for today. Over to Dr. G.S. Chaudhary, sir.
Thank you, Dr. Vikas, and it's an honor to share the dais with Dr. Advani. And I think, has Sir joined in?
So he will take a minute or so you can start and invite the first speaker, sir.
So I will follow the timeline, the army style, and without wasting much time, I would request Dr. Shruti Kate, who's a consultant and head of Department of Medical Oncology at the HCG Manwata Cancer Center at Nashik. And this is the first of a series of 5 talks, and each will be for around 7 minutes each. And she would be giving a talk on adjuvant palbociclib in hormone positive HER2 negative breast cancer in the early stages. And this is final results from the phase 3 PALAS trial. And over to Dr. Shruti Kate, please.
Thank you so much, Dr. Chaudhary. And at the outset, I would like to thank the organizers for giving me this opportunity. And without much delay, I would like to start. So the trial that I have been asked to present is the PALAS trial. It's adjuvant palbociclib in HR positive, HER2 negative, early breast cancer patients, a final protocol planned analysis of 5,761 patients. This was presented on the behalf of PALAS groups and investigators by Dr. Michael. Next slide, please. So we know that CDK4/6 and endocrine therapy prolongs progression-free survival and overall survival in metastatic HR positive, HER2 negative breast cancer patients with good tolerability. But unfortunately, there is a subset of patients which would be ranging from around 20 to 30% who actually recur during the course of their lifetime. And that is actually an unmet need here. There are several large clinical trials which are investigating CDK4/6 efficacy in this curative early breast cancer setting. So PALAS trial, it's a global phase 3 trial, which investigates whether the addition of palbociclib to adjuvant endocrine therapy improves outcome compared to endocrine therapy alone in this HR positive, HER2 negative early breast cancer patients. This is the trial design, beautifully designed study. Stage 2, 3 patients were at a with without, and they were randomized 12 months of diagnosis, and within that they were adjuvant therapy.
Hello, Shruti ma'am, can you hear us?
The audio is out.
Team connects with Dr. Shruti. May I have the honor of inviting Dr. Advani sir? Meanwhile, Dr. Advani sir needs no introduction. He is the father of medical oncology. As we know, across the globe and in India, has been an teacher for decades of students, and it brings us great honor for having him on board on a Sunday morning. With his blessings, we are going to start the session.
Good morning, sir.
In the beginning,
Sir,
but it's really nice to attend this.
good morning, sir, and honor to share the dais with you.
Thank you. Yes,
I think there's some connection issues with Dr. Shruti, so.
connection is the issue.
Not with you, sir. The first speaker. Yours is perfectly fine, sir. Your audio and your voice and your aroma and your whole hello is perfectly fine, sir.
Okay. Yeah.
I'll just switch off my video. Yeah.
Yes, ma'am. That's perfect, ma'am. So you're clear. We'll share this.
Yeah. Can you put up my slides again?
Yes, ma'am. Ma'am, can you just see the slides and then you can start them? Hello?
Yes.
Okay. With the permission of chair, is it possible, Dr. Chaudhary, can you invite the next speaker? Can we have Dr. Mansisha now, and we can take up the Dr. Shruti's presentation later. Dr.
Yeah,
Chaudhary,
I think that would be better. If it is the connection is taking time, we can go ahead with the next presentation.
So thank you, sir. So without wasting much time, while Dr. Shruti Kale reconnects with us, we'll invite Dr. Mansi Shah. Dr. Mansi Shah is a consultant medical oncologist at the HCG Center at Ahmedabad, and she's going to talk to us on the correlative analysis of overall survival by intrinsic subtypes. And she's going to correlate this along Mona Lisa 2, 3, and 7 studies, which use ribociclib and endocrine therapy in the subset of patients we're discussing today, which is hormone positive and HER2 negative advanced breast cancer. Over to Dr. Mansi, please.
Good morning, everyone. It's a great pleasure to be here this morning. And good morning to the chairpersons, Dr. Chaudhary and Dr. Advani. Will you be able to share my slides, or should I share slides?
ma'am, is it okay if you can share your slides? I think you
Okay,
can have
sure.
a control.
Sure.
Yes, we can see your slides, ma'am. All yours, please.
Okay. So today I was asked to present this abstract, which was presented at the SABCS, which looked at the correlative analysis of overall survival by intrinsic subtype across the Mona Lisa trials in patients with hormone-positive, HER2-negative advanced breast cancer. So just as a background, we all know that ribociclib and endocrine therapy has demonstrated statistically significant progression-free survival and also overall survival benefit in the phase 3 clinical trials, the Mona Lisa 2, 3, 7, in this subset of patients. And there was a prior pooled analysis of patients in the Mona Lisa trials, which demonstrated a significant PFS benefit with ribociclib plus endocrine therapy in the luminal A, luminal B, and the HER2 enriched subtypes. So this retrospective exploratory analysis is taking it forward and looking at the overall survival using tumor samples pooled from these 3 trials. So the way that they did it is they collected tumor samples from the patients in these 3 trials, and they did gene expression profiling using a nanostring NX counter GX800 gene panel. And the intrinsic subtype was performed using the PAM50 subtype in 48 independent tumors. The original PAM50 microarray training data set was used. The relationships between the PAM50 subtypes with overall survival were evaluated using univariate and multivariate Cox proportional hazard models. Kaplan-Meier curves were generated, and the median overall survival was estimated by the subtype and treatment arm. The multivariate models were adjusted for known clinical prognostic factors. The p-values were descriptive and not adjusted for multiplicity or false discovery, since this was a retrospective analysis. So if we look at the subtype distribution in the pooled data set, we can see that about 70% of the tumor samples were from the primary tumors, 70% from the Mona Lisa 2, 3 trials, 68% of the primary samples from the Mona Lisa 7 trial. And if you look at the distribution of subtypes as expected for hormone-positive breast cancers, we are seeing majority of these tumors as luminal A tumors, 54%, luminal B tumors, 28%. There were about 15% HER2-enriched tumors, and a small subset, 3% of basal-like tumors. Based on the previous intrinsic subtype studies that have been done in hormone-positive settings, we do see a certain percentage of patients who are HER2-enriched as well as basal-like, even though these tumors are hormone receptor positive. So when we look at the overall survival benefit and the intention to treat population and the biomarker populations, we see that there is a similar benefit across these populations. The intrinsic subtype was prognostic for overall survival, which means that if you have luminal A tumors, these patients tend to have a better overall survival, median OS of about 54.6 months in the placebo arm and 68 months in the ribociclib plus endocrine treatment arm, and so on and so forth. So luminal Bs, they tend to do better whether you give them placebo or ribociclib, but of course, there is a benefit of adding ribociclib, 44.9 months versus 58.8 months. The patients that don't do so well are the basal-like tumors, where the median overall survival is 21.2 months in the placebo plus endocrine therapy arm versus 19.4 months in the ribociclib plus endocrine therapy arm. Even when we account for the clinical prognostic factors as used in the multivariate models, the intrinsic subtype still was prognostic for overall survival in these models. So the subtype remained prognostic for OS in both arms after adjusting for the clinical factors. So what this says is pretty much the same thing. It's just a pictorially placed. So the interaction test between the subtype and the treatment arm remains statistically significant after adjusting for clinical covariates, the p-value being 0.065. After removing the basal-like subtype from this analysis, the interaction test was no longer statistically significant. If we see the basal-like subtype was only 3% of the total population, so it was a small number. And hence these results should be interpreted with caution due to the small sample size. However, the conclusion is that in this pooled analysis of the Mona Lisa 2, 3, and 7 trials, which includes patients who are postmenopausal as well as premenopausal, perimenopausal, and the endocrine therapy arm, as we all know, is either an AI or fulvestrant or ovarian function suppression plus an AI as well as tamoxifen. There is a consistent OS benefit which was observed in the ribociclib arm in the luminal A, B, and the HER2-enriched subtypes. The prognostic value of PAM50 based intrinsic subtype was confirmed in this analysis. This is confirming the prior analysis of PFS using the same subset. And one of the hypotheses why ribociclib plus endocrine therapy might work more in the HER2-enriched subtype is that it increases endocrine sensitivity in these patients. This is being further investigated in the Harmonia 3 trial, where they're comparing actually ribociclib in particular HER2-enriched tumors. So the take-home message from this trial or this analysis is that hormone-positive, HER2-negative advanced breast cancer is a clinically heterogeneous group of tumors with different prognosis and responses to endocrine therapy. The addition of CDK4 inhibitors to endocrine therapy is now standard therapy for most patients because of clinically meaningful increases in both PFS and OS. In this context, however, we have no prognostic or predictive biomarkers that can be clinically implemented, and this study suggests that intrinsic subtypes might be useful in correlating with PFS and OS benefit of adding ribociclib. This meta-analysis does have certain limitations. It is an ad hoc exploratory analysis combining 3 phase 3 randomized trials. Hence, the lack of statistical significance in some of this analysis could be due to lack of statistical power. The findings were not adjusted for false discovery or multiplicity. And a majority of the tumor samples were primary tumor samples and not metastatic tumor samples. So unable to address whether the type of tumor tissue affects prognosis or treatment benefit. Thank you so much. If there's any questions, I'd be more than happy to take them.
So Dr. Chaudhary, sir, you need to unmute, please. Yeah.
So if there are any questions to Dr. Mansi Shah, we can take them now.
So you can invite the next speaker, sir, Dr.
Okay.
Shruti, please.
So if there's none, we'll now request Dr. Shruti Kali to come and please give your talk on PALAS 3 trial. We lost you in the connection, so this was the first talk. Dr. Shruti, please.
So sorry, sir. My sincere apologies for the network issues. And let us continue the presentation on PALAS trial presented by Dr. Michael Knapp in the SABCS 2021. So next slide, please. We were discussing the study design, beautifully designed study for stage 2-3 HR positive, HER2 negative patients who had completed prior surgery with or without chemo and radiation. These were randomized to within 12 months of diagnosis or within 6 months of starting the adjuvant endocrine therapy. The tumor block was submitted and received at the bio repository. 5,600 patients were planned to be enrolled. These patients were all stratified as per the stage 2A versus 2B or 3, whether they had received chemotherapy or not, age less than 50 or more than 50, geographic region US versus the other regions. So these patients were then randomized into 1:1 ratio into the palbociclib arm, which received palbociclib 125 milligram every 3 weeks for 3 weeks on, 1 week off for 2 years, along with endocrine therapy, which could be AI or tamoxifen with or without ovarian suppression. The other arm included the endocrine therapy alone. The primary endpoint of the study was invasive disease-free survival. Next slide, please. These are the other endpoints. The primary endpoint was measured using the STEEP criteria. Secondary endpoints were IDFS, excluding the second cancers of non-breast origin, the eye, breast cancer-free survival, distance recurrence-free survival, local regional recurrence-free survival, overall survival, and safety. Another endpoint which is under analysis currently is the translational biomarker related analysis of these patients' samples along with the QOL and the PRO data. For a target hazard ratio of 0.75, 5,600 patients were planned to be enrolled with a one-sided alpha of 0.025 to achieve an 85% power. This final analysis has been undertaken after an occurrence of 469 events. Next slide, please. So this is the recruitment. Recruitment was initially slow and then it picked up there were equal enrollment from the US and the non-US regions. Next slide, please. So like I said, 469 IDFS events were observed before this presentation was made and the data was published. Next slide, please. And the current trans-PALA study is on the way, which we will be discussing in a little while. So this is the baseline patient characteristic. A total of 5,761 patients were randomized in an intention to treat population. Majority of them were higher stage, 2B and 3. Majority of them had received prior chemotherapy. Median age was 52 years and clinically high risk, which was based on the scoring that was also used in the Penelope trial. The ER positivity as well as the node positivity was around 59%. Next slide, please. So as such, no new safety signals for palbociclib treatment were observed. Overall, 13% of patients developed a severe adverse event, but none of these 176 deaths that were seen in the trial were related to the study treatment. Next slide, please. Also, the rates of palbociclib discontinuation were closely monitored because this is an adjuvant treatment protocol. Early discontinuation within 6 months was observed in 17%, and at the end of 2 years, around 44.9% of patients had actually discontinued palbociclib. The final analysis data confirmed earlier result that longer palbociclib duration or more than 70% of dose intensity did not actually markedly improve the eye DFS. Next slide, please. This is the primary endpoint IDFS curves. So at the end of 4 years, IDFS in the palbociclib plus endocrine therapy arm was 84.2, similar to the endocrine therapy alone arm. Hazard ratio was 0.96. So at the end of follow-up of 31 months, no significant difference in 4-year IDFS was observed. Next slide, please.
Ma'am, you have a minute to conclude, please.
Yes. So these are the subgroups that were analyzed, but there was no significant difference in any of the subgroups. Next slide, please. So other secondary endpoints were also not different. Next slide, please. Next slide, please. So to summarize, there was definitely no benefit whatsoever for addition of palbociclib to adjuvant endocrine therapy in this group of subgroups. Next slide, please. This is the monarch E curve that is directly compared with this study because abemaciclib 2-year data showed a definite a prolongation of the invasive disease-free survival in high-risk HR positive, HER2 negative population. Next slide, please. So why this difference? So all these studies, Penelope D, Palas, Monarchy, have been selecting patients quite differently. Monarchy is the only study that selected patients based on the proliferative index, the grade, as well as the TI60, which was more than 20%. If you look at the drug exposure that is continuous in abemaciclib could have made the difference. As such, at the drug level, though the pharmacokinetics is different, in the metastatic settings, there is no clinical difference in efficacy, but there could be certain points like in the neoadjuvant palbociclib data, we have seen that palbociclib works more in the luminal subgroup of patients. Next slide, please. This is how the treatments have been different in all these trials, looking at the adjuvant use of CDK4/6. Next slide, please. And this is the trans-PALAS analysis, where the serial tumor biopsies as well as the blood samples are going to be analyzed for biomarkers and proliferative markers. Next slide, please. And this is going to definitely provide an excellent reasoning to exclude or select patients who are going to benefit from this drug intervention in the adjuvant setting. Next slide, please. So to conclude, the benefits definitely in PALAS did not translate in an earlier adjuvant use of palbociclib. Long-term follow-up is definitely required, and the ongoing trans-PALAS translational and clinical science program with almost 6,000 tumor blocks and 10,000 blood samples will definitely improve our understanding of CDK4/6 inhibition as well as contemporary management of HR-positive, HER2-negative breast cancer patients. Next slide, please. Thank you.
Thank you, Dr. Shruti. And without wasting much time, we'll now request Dr. Advani, sir, if you have anything to ask or any questions or any comments from your side, sir.
No, please, I think we can move on to the next presentation. Okay. Already we are delayed.
You would like to invite the next one, sir? So I'll invite Dr. Kripa Bajaj, who's a consultant medical oncologist from Baswantakram Indo-American Hospital at Hyderabad. And she'll be talking on the OS in the Mona Lisa 2, looking at the subtypes of the metastatic sites in hormone-positive, HER2-negative breast cancer. Ma'am, please.
Thank you, GS Chaudhary sir, for introduction, and good morning to both the chairpersons. And at outset, I would like to thank both organizers for giving me this wonderful opportunity. Without wasting much time, we'll switch into the discussion. Can someone share the screen, or like, you want me to share the slides?
You can share the slides, please.
Sure. So I'm going to discuss the overall survival subgroup analysis by metastatic site from the phase 3 Mona Lisa 2 study. That's a first-line ribociclib plus letrozole in postmenopausal, hormone-positive, advanced breast cancer patients. So what is the conclusion of this one? I just want to introduce in the initially beginning itself. We all know Mona Lisa 2 is done in postmenopausal females in the first line with the ribociclib plus letrozole combination compared to the letrozole. The conclusion of this study is there's a significant difference in the overall survival with addition of ribociclib to letrozole. That is 63.9 months versus 51.4 months. So now we are going to discuss, it's an exploratory OS analysis on patients of Mona Lisa 2 subgroups by the location of metastasis as well as number of metastatic sites and prior therapy. So this is a study design. We all are very well aware of this one. It includes postmenopausal advanced breast cancer patients. It's a first-line therapy. They can take neoadjuvant or adjuvant endocrine therapy, including Tamazala. Later, it was stratified into two arms. That's ribociclib plus letrozole versus letrozole. And the primary endpoints is a PFS. Key secondary endpoint is OS. Select secondary endpoints are overall response rate, as well as safety, quality of life, as well as, clinical benefit rate. So if you see the curves, there is a significant OS benefit is noted in the ribociclib plus letrozole arm. The median OS is 63.9 months, as already mentioned, versus 51.4 months. At 5 years, it is 52.3% versus 43.9%. Significant, almost like 10% benefit is there. At 6 years, the same holds good. It is 44.2% versus 32%. This is total Mona Lisa 2 intensity population curves. What are the methods like used in this analysis? The data cutoff for this analysis was June 10th, 2021. The pre-specified subgroups determined by baseline location of metastasis, number of metastasis, and prior therapy it was included in the exploratory OS analysis. It was again stratified by bone-only metastasis, liver involvement, liver or lung involvement put together, and number of metastatic sites, prior chemotherapy or prior endocrine therapy. The OS was estimated using Kaplan-Meier method. Hazard ratios were estimated using stratified or unstratified Cox proportion hazard models. This analysis, as already mentioned, is exploratory. It was not powered for significance or adjusted for multiplicity. So this is the bone-only metastasis curves. So the left side and the right side. So if you see, the OS benefit in patients with or without bone metastasis was consistent with the intention population. You see, left side is the bone metastasis, right side the no bone metastasis. In both groups, there is significant benefit was noted in the OS. The curves are clearly separated. So that is 58.6% versus 47.1 at 5 years. And at 6 years, it is 50.2 versus 33.8. When there are no bone metastasis, it also holds good. It is 50.6% versus 43%. And at 6 years, again, 42.6 versus 31.5. And next, it's liver-only metastasis. Again, if you see at 5 years as well as 6-year analysis for both liver as well as no liver metastasis, there's a good OS benefit was observed. So at 5 years, it is 37.2% versus 28.4, and at 6 years, 31% versus 18.9. So we all know liver metastasis patients comparatively do poor compared to bone-only metastasis patients. So across the viscera, also liver metastasis is always an interesting topic to discuss. In this one, if you see liver metastasis patients, there is a good benefit by addition of ribociclib to letrozole. When there are no liver metastasis as expected, there's a good survival benefit is there, and still by addition of ribociclib, the survival benefit is like still increased. At 5 years, it is 55.2 versus 48.3, and at 6 years, it is 46.8 versus 35.7. So clearly, liver metastasis patients, whether it's there or not, they benefited significantly. Compared to liver or lung, again, in the patients like both groups, whether it's a liver metastasis present or not, like they got benefited. And liver or lung metastasis patients put together, that's a good benefit was noted. It is 5 years, it is 48.2% versus 55.4. And as the Taylor, it's at 6 years, if you see, there is significant difference noted. That is 40.5% versus 31.2. It's almost 10% difference.
Your audio is wavering.
So expected one, when there are no visceral metastasis like liver or lung. I'm sorry, 1 second, I'll stop my video. That's better. Is it clear now, sir?
Yes, clear.
Is it clear now?
Yes,
yeah.
yes.
So when there are no liver or lung metastasis as expected, the survival is better. It's almost 57.1 versus 41.9%. And also at 6 years, 48.6 versus 33.2%. Significant benefit was noted, whether liver mets or lung mets are there or not. Both groups got clearly a very good benefit with the addition of ribociclib. Yeah. So with the number of metastasis, less than 3 and more than 3, though it's like not technically like oligometastatic though, in the sense like up to 5 we can include. So less than 3 versus more than 3 got analyzed. When it was noted in less than 3 metastasis, 5 years and 6 years, that's a good benefit, like 54.8 versus 46.9 and 47.4 versus 36% was noted. And more than 3 mets were noted compared to definitely less than 3. The survival is like relatively less, but still addition of ribociclib scored really well in these patients. It is almost 10% to 15% differences noted at 5 years and 6 years analysis. So by patients who ever received prior chemotherapy, yes versus no. The patient who received chemotherapy prior, at the 5 years, it is 44.1% versus 37.3. And again, 6 years, it is like nearly 40 versus 25. So whoever received chemotherapy, at 6 years, if you see, it's almost 15% difference is noted, suggest a very significant benefit by ribociclib. And also whoever didn't receive chemotherapy, if you see, clearly these patients do well. It's almost like upfront setting. So that 5 years is almost nearly 60% patient got benefited, and 6 years, it's nearly 48% people got benefited. So both groups got a very good benefit by addition of ribociclib. And prior endocrine therapy, it's always the topic of discussion regarding endocrine resistance in patients who received prior endocrine therapy. If you see, clearly patient who didn't receive without any endocrine therapy, they score really well. That is 5 years and 6 years. It's almost significant differences noted by addition of ribociclib. That is 58.6 versus 44. And at 6 years, again, 47.6 versus 35.2. But the patient who received NSAIDs or tamoxifen, whatever, or the sequencing of hormone therapy as an adjuvant setting, still they got a very good benefit by addition of ribociclib. If you see the NSA and others at 6 years, if you see, it's almost like significant difference, nearly 25% difference is noted, which is unheard. So, and again, the tamoxifen group, the same 10% benefit was noted at 6 years analysis. So clearly, whether the patient received or not received endocrine therapy, all groups got benefited. We see a bit more benefit in the patient who didn't receive endocrine therapy, like obviously many reasons were noted biologically. But if you see the NSAIDs or sequential therapy intake or tamoxifen intake, these patients also, they got benefited significantly. So
Dr. Kripa, ma'am, last minute to conclude, please.
Yeah, it's over. It's conclusion already. So my conclusion is, independent of the metastatic site, number of metastases or prior neoadjuvant or adjuvant chemotherapy or endocrine therapy, this exploratory subgroup analysis demonstrated significant improvement in survival with first-line ribociclib plus letrozole compared to placebo plus letrozole in postmenopausal patients which are strongly HR positive advanced breast cancer in MONALEESA 2 trial. So consistent improvement was noted in the long-term survival at 5 years and 6 years with ribociclib in all subgroups which were analyzed. So MONALEESA 2, MONALEESA 3, MONALEESA 7, they have demonstrated consistent OS benefit with ribociclib, regardless of the endocrine therapy partner, line of therapy, or menopausal status. Once again, I thank organizers for giving me this opportunity. I'm happy to take any questions or discussion.
Yeah, thank you, Dr. Kripa Bajaj. Dr. Advani, sir, would you like to make a comment?
Yeah, I think in all these studies,
Your audio.
In all these studies, the degree of estrogen receptor or progesterone receptor positivity is not mentioned. I think this is very important. In our practice, we see that if they are 90% positive, they are definitely doing better as compared to those who are 20% positive. So what is the sort of a degree of estrogen receptor positive in MONALEESA trial?
So that subgroup analysis, the percentage cutoff, it was not analyzed, sir. I think like that's a very good input which you have given. It's definitely like a very good stratifying factor to look into. But it was not analyzed separately. It was not mentioned in anywhere else.
So at what percentage they call it ER positive? 10% they'll call it positive, 90% also?
No, sir. No, 10% definitely ribociclib will not benefit for sure. It's almost like going to the HR negative side, but HR positive definitely we would like clinically, we all of us use more than 40 or 50. So usually 30% or less, like we usually don't see great benefit. Must be what your input is really valuable. That's a very good subset to analyze.
Thank you.
Also, was there any subsite analysis for the CNS done, ma'am?
CNS, no, sir.
Okay, because ribociclib is now being tested
Abemaciclib only, yes, sir,
which
yes.
abemaciclib penetrates, but ribociclib is now being tested in pediatric brain tumors also. That's why I asked. So thank you for your talk, ma'am. And now we can go ahead to the next session, the fourth talk, and we'll invite Dr. Neeti Raizada. She is a well-known medical consultant from Fortis, Bengaluru, and is the director of oncology and hematology there. She will be talking on updated results from the phase 3 trial of which is an RCT of 1 to 3 lymph node subgroup of hormone positive HER2 negative breast cancer patients who had a recurrence score of around 25, and then they were randomized. I think we'll go over to Dr. Neeti Raizada, please.
Thanks so much, Dr. Chaudhary. Thanks to the sponsors for the meeting today, and thanks to the chairperson, Dr. Advani and Dr. Chaudhary for inviting me today. So I'll be speaking on the RX Ponder study. Now, I would say that till 2000, I think we had a blanket understanding that any person who's diagnosed with breast cancer should receive chemotherapy at some point in time. And Oncotype DX probably was the first predictive and prognostic marker with a 21 gene recurrence score testing done, which decided whether we can eliminate some patients of early breast cancer and give only endocrinal therapy and not chemotherapy. And the first step towards this was node-negative, hormone receptor-positive breast cancer patients, early breast cancer patients. And the data we had was from the TAILREX study, which was published in the past, which used all landmark working groups. And now we have RX Ponder study, which actually deals with subset of population, which are less than 25 breast recurrence score, endocrine responsive breast cancer, early breast cancer patients who have 1 to 3 lymph node, and also includes a subset of patients with micrometastatic axillary lymph node positivity. So until now, the vast majority of patients with early breast cancer did not benefit from adjuvant study. And this study was basically, we found out this by Early Breast Cancer Trialist Collaborative Group meta-analysis, which was published in 2012, which showed that the absolute benefit was only about 8%, which was noted at 10 years. So then we started working on the subtypes. And as I said, TAILREX study was the first study, which was a predictive study for node-negative breast cancer, where we had low risk, low recurrence score, intermediate recurrence score, and high recurrence score. And recently we had data for intermediate recurrence score, whether they should be given chemotherapy or not. So this is the study which we'll be talking today. And well, we had SWOG analysis. The current study, the RX Ponder study, was basically taken up by NCI Working Committee, SWOG, and it is known as SWOG 1007 study, which was based on the SWOG 8814 study, which definitely showed that recurrence score of 31 to 100 had an absolute chemotherapy benefit of 91. RX Ponder was an NCI-sponsored study in the United States, but other working groups like Hope Foundation and BCR Foundation helped in Mexico, France, and Spain. So this was a SWOG 8814 study in which the recurrence score more than 25 favored the use of chemotherapy. Now, RX Ponder was basically a study of 5,000 patients, which were randomized in a certain way of all the women who were 18 and above, who had node positive disease, that is 1 to 3 lymph node positive, that is N1 status, which were HR positive and HER2 negative. The stratification was based on the risk scoring, that is 0 to 13 versus 14 to 25, whether they were premenopausal and postmenopausal, whether they had sentinel lymph node biopsy or axillary lymph node dissection. So all these patients was further randomized into endocrinal therapy alone or chemoendocrinal therapy. The recruitment was voluntary and based on understanding that there could be a risk of failure. The clinical evaluation parameters were IDFS, that is invasive disease-free survival, DRFS, which is distal relapse-free survival, distant recurrence-free survival, and overall survival. So RX Ponder study was randomized 1:1 based on all the characteristics, whether they were pre or postmenopausal, whether lymph node status was 1, 2, or 3, whether it was micrometastatic or macrometastatic disease, whether sentinel lymph node biopsy or axillary lymph node sampling was done, what was the grade of tumor, what was the tumor size. Almost 5% were T3 disease, all the others were T1 or T2, or whether it was clinical risk score low or high. So what happened in the postmenopausal group? Well, in the postmenopausal group with N1 postmenopausal status, the invasive disease-free survival and the distant relapse-free survival did not favor the chemotherapy arm when it was analyzed and updated at 6.1 year of median follow-up. This lack of benefit was seen in all the subgroup. There were about 2/3 of the patients who were more than 65 years of age. About 2/3 of the patients were, almost 95% of the patients were T1 or T2. Almost 2/3 of the patients were high risk. Almost substantial patients were 1 lymph node status, and 2 to 3 lymph node status were about 1/3 of the patient. And as I said, this benefit was not seen in any risk grouping. There was no statistical significant difference between 0 to 13 RS status or the recurrence score of 14 to 25. Now, the postmenopausal status did not show any benefit difference, whether it was 1 lymph node positive or whether it was 2 to 3 lymph node positive. What happened in the premenopausal subgroup? Well, in all the subgroup, there was a slight improvement in the chemotherapy subgroup, whether it was in terms of invasive disease-free survival or in terms of distal relapse-free survival. This was seen in terms of approximately 3% of 5-year free relapse scoring. relapse-free interval scoring. And this benefit again was seen around all subgroups, whether it was grade or nodal status or recurrence score. So there was this benefit seen in 0 to 13 recurrence score, or whether it was 14 to 25. There was a small subset of 200 patients in this study, which was micrometastatic disease. And this benefit was also seen in the micrometastatic axillary lymph node involvement. Now, the only thing which is noteworthy and which this trial could not conclude was this effect, the benefit of ovarian function suppression. In this study, most of the chemotherapy, almost 80% of the patient used TC as the chemotherapy. That is docetaxel along with cyclophosphamide, which has currently become the standard of care in early breast cancer. And what was not clear was whether it is the effect of cyclophosphamide used in the non-anthracycline-based combination or even in the anthracycline-based combination. And this benefit was basically seen in the first 2 years of the woman who attained menopause immediately after starting chemotherapy. This benefit was also seen higher when the age group subset analysis of 45 to 50 was done, which tend to have earlier menopause. So the rate of regular periods was assessed, and it was found that the women who attained early menopause, that is in the first 2 years of therapy, had higher benefit. So in conclusion, the majority of the node N1 postmenopausal women could be spared chemotherapy based on the recurrence score if it is between 0 and 25. The premenopausal women with N1 nodal status with the recurrence score of 0 to 25 had about 2.4% benefit across all subgroup. This study was not powered to do a subgroup analysis difference, although the number of subjects were pretty high, that is about 5,000. And what we have to understand is based on the international data, United States data, Israel data, and the global data, most of early breast cancer fall in this subset. So it basically endocrine receptor positive, most of them would have a scoring of 0 to 25. Almost 85 to 90% patients would fall in the 0 to 25 subset, a risk scoring subset. And therefore, we have to understand what we need to do in our subset of population. And until we start using Oncotype DX or other predictive score regularly in our practice, we'll still have unanswered query. With this, I end my talk. Thanks so much.
Thank you, Dr. Neeti. And Dr. Advani, sir?
No, I think please. Go ahead.
Thank you, Dr. Neeti. If there are any questions from anybody's side, you can please address them now. And since so, would you like to? Yeah.
So you can invite the next speaker, please.
Okay.
Chaudhary,
So we would. So
if I can ask Dr. Neeti, Dr. Meeno Walia here.
Please, ma'am.
Dr. Neeti, what is your clinical practice? In today's, yes, the data is very impressive, but what we, in a today's state, if it is like postmenopausal, 50 plus, a lady may be postmenopausal. So 55-year-old lady, and with a lymph node, with 2 lymph nodes positive, 3 lymph nodes positive. So what are we doing in our clinical practice? We will go by the RS score and not give chemo. Are you asking Oncotype DX in this subgroup?
Ma'am, I definitely asked for Oncotype DX when it was node negative disease. I mean, we had this RX Ponder data, which has come up only recently. And until now, I have not started using it in my practice. With a 3 lymph node status positive, based on the T scoring, most of the time I will try to give chemotherapy in such patient. But at the same time, I think with more and more evidence supporting not using chemotherapy, the only glitch in the story is Oncotype DX is given after we have the surgical pathology report, and then it takes 3 to 4 weeks. So actually we are wasting about 7 to 8 weeks before we are making decision. So it probably is a golden time when we are losing the benefit of adjuvant. Until we have very easy access to these tests, I think we'll still have to decide a treatment based on clinical parameters.
Yeah. Thank you.
Thank you. Now we'll invite Dr. Shivam Singla, who's a consultant oncologist from SL Raheja, who needs no introduction, for his talk, please.
Can you share my slide, Tarunji, and disable my video? I'm not able to.
Sure, sir.
Disable the video. So thank you, the organizers, for inviting me for this talk. I've been looking forward to this topic of using CDK4 inhibitors in HER2 positive space. These are the patients who are triple positive. Something which I've been pondering myself, whether there is any data to support this usage. So this is the study which I am going to sort of read out in front of you. Palbociclib plus trastuzumab in HER2 positive metastatic breast cancer, subset analysis from the Patricia trial, the final results from cohort A and B perspective. It was a phase 2 study. The number of patients enrolled were very low. CDK4/6 inhibition combined with HER2 therapy is currently being explored in HER2 positive patients. This is a subgroup which comes up in our clinical practice quite frequently, and we are tempted to, add multiple agents. But due to lack of data, a lot of clinicians feel, uncomfortable. The main purpose of this SALTI 1303 Patricia study is to evaluate the efficacy of CDK4 inhibitor with the HER2 anti-HER2 agent in a metastatic breast cancer. The final this trial reports, this paper reports the final efficacy, overall survival, and genomic analysis of both the cohorts. Next slide. So the objectives of this study was to identify, which cohort is the drug working. This study was based on Simon two-stage design, where you have to have 60% of the patients surviving on a particular intervention to go ahead. The three cohorts were: the cohort A was estrogen receptor negative cohort B was estrogen receptor positive cohort, and cohort B2 was estrogen with letrozole cohort. And treatment consisted of palbociclib 200 mg daily for 2 weeks, followed by 1 week off. I do not know as of now, until I get a complete analysis of this paper, why was 200 mg chosen and 2 week, 1 week regimen. I assume this was to match with the frequency of trastuzumab, which was given every 3 weekly. The primary endpoint was progression-free survival at 6 months. The secondary endpoint was PFS, OS, and association with the PAM. Next slide. So results of this 2021, all patients had a progression-free event. 50 out of 71 patients had died. Median overall survival was concluded, analysis. Next slide. So you can see here in the Kaplan-Meier analysis that based on the PAM50 subtype, the
Dr. Shivam, your audio is not connecting.
luminal subtype of the disease did better than the non-luminal type. Can we go to the next slide? Here we can see that on the first plot is that luminal A and B were better in terms of PFS, whereas overall survival was better in patients with luminal A. Basal type patients did not benefit from the intervention. Majority of these patients were beyond 2 to 3 or 4 lines of therapy. The intrinsic subtype of luminal versus non-luminal, the progression-free survival and overall survival were statistically different between the intervention arm. Can we go to the next slide? So the conclusions of this small group of study was that this was a promising progression-free survival in patients treated with trastuzumab, pre-treated ER positive patients with PAM50 scoring, with done with PAM50 of luminal A, B subtype. They maintained, the benefit was maintained with more than 3 years of follow-up. Longer overall survival was seen in patients with luminal subtype of tumors, but the results were not statistically significant because this was probably, because of the small sample size. Cohort C of the Patricia trial is currently randomizing patients with hormone positive, HER2 positive, PAM50, luminal A or B to palbociclib and endocrine therapy plus trastuzumab or the treatment of physician choice. I think we are awaiting the conclusion results from this exciting trial.
Thank you very much.
Thank you, Dr. Shivam. And without wasting much time, we'll go over to Dr. Shifali Sardana, who's from a consultant oncologist from Max Super Specialty Hospital, Saket, to give her concluding remarks. Probably, ma'am, you'll have to shut down the time from 20 minutes to maybe 10 minutes. And you'll be talking about bringing together clinical trials and real world data in this subset.
Sure, sir. Morning, everyone. Morning, sir. Thank you, organizers, for giving me this opportunity. It's basically a Pfizer-sponsored session. So my disclaimer is that slides are provided by Pfizer only. So is my screen visible?
Yes, ma'am, you have to go on the slideshow mode.
Yeah. So
Fine, ma'am.
Yeah, so good morning again, and I'll be presenting the ER positive, that is hormone positive, HER2 negative MBC, the clinical trial and real world evidence. And without wasting time, I would just mention that starting from tamoxifen in 1970s, the journey of metastatic MBC and evolution of various hormone therapies along with the targeted therapies took approximately say 30 to 40 years to come up with the targeted therapies, which actually revolutionized the treatment of hormone positive metastatic MBC. And we know that CDK4/6 inhibitors plus hormone is the first line treatment for the metastatic hormone positive breast cancer, and it is indicated in the first line de novo with the combination with aromatase inhibitor and in second line with fulvestrant. And when we see the global first line phase 3 data, so we have 3 drugs in pipeline, that is palbociclib, ribociclib and abemaciclib. And if we compare or see the first line data for all of them, you can see that hazard ratio is approximately matching in all of them, and with a hazard ratio of 0.56, 0.54 and 0.56 in respectively each of them. And out of these, the phase 3 trial randomized data, the overall survival has reached maturity in case of ribociclib, which is 63.9 versus 51.4 in ribociclib plus hormone therapy arm as compared to hormone alone. Coming to the study design of PALOMA-2, we all know it was first line setting, treatment naive, or patients who have progressed more than 12 months on adjuvant setting of hormone. So these patients were included and randomized in 2:1 fashion to palbo plus letrozole versus letrozole plus placebo. And if you see that PFS in intention to treat population, we know that the results were impressive with the PFS of 27.6 months in the PAL-base plus letrozole arm versus letrozole alone. So if we see this forest plot, and we can see that CDK4/6 inhibitor, that is PAL-base plus letrozole, fares absolutely well in all of the subgroups as compared to the hormone therapy alone, be it the visceral disease, be it bone-only disease, non-visceral disease. And as you decrease the quantum of disease or the bone-only thing, the hazard ratio becomes more impressive. And if you see, I mean, in age group less than 65 versus more than 65, it did fairly well. Having said that, meaning that this drug is comparatively safe in the elderly age group also. So this trial concluded that after 37 months of follow-up, the median PFS was impressive, and it should be regarded as an important first-line therapy option for patients with hormone-positive metastatic breast cancer. If we see the second-line trials, again, the 3 drugs in pipeline, and if you see the trial design and previous chemotherapy for MBC patients was included in PALOMA-3 only. And this subgroup analysis shows that median PFS was again comparable and almost comparative in all 3 drugs, that is 0.50 in PALOMA-3 versus 0.53 in Monarch and 0.58 in Mona Lisa trial. So if we see the study design in this second line setting, the patients who were on or within 12 months of completion of adjuvant treatment or on or within 1 month after treatment of MBC less than equal to 1 prior chemotherapy regimen was also permitted. And these patients were included, be it pre or perimenopausal or postmenopausal, and they were randomized into 2:1 fashion to palbociclib plus fulvestrant arm versus placebo and fulvestrant. And primary endpoint was investigator assessed PFS. And if we see these overall survival analysis, so in pelbase plus fulvestrant arm, the median OS was 34.9 months versus 28 months in the fulvestrant alone arm, with an unstratified hazard ratio of 0.79 as compared to and the updated analysis at 73.3 months also consistently showed the maintenance of PFS advantage and OS advantage. So if we see in menopause, according to the subgroup analysis, according to menopausal status, so I think this drug fairly did well in both of the subgroups, with median PFS of 9.5 months in the pre or perimenopausal age group, and as compared to 9.9 months in postmenopausal age group. So all of these patients in pre or perimenopausal age group had that this goserelin or GnRH analogs included along with the pelbase and fulvestrant. This trial also concluded that a median PFS of 11.2 months was seen with pelbase and fulvestrant as compared to fulvestrant alone, and it was well tolerated, and it is an effective treatment option for women whose tumor has progressed on prior endocrine therapies. So a 10-month improvement in OS was also observed in patients with sensitivity to prior hormone therapy. If we see the safety analysis, I think all of these drugs now what we are using, we are becoming more wiser. It is basically the patient selection or the choice of patients according to the toxicity profile, and these drugs all are comparable and at par with each other. So if we see palbociclib, it has more of the hematological toxicity in terms of neutropenias. Ribociclib has an safety concern for cardiac toxicity in the terms of QTc prolongation and as well as hepatotoxicity. And if we see abemaciclib, we know diarrheas do trouble our patients, and along with the monitoring of liver profile. So this is the comparative safety analysis of all of the three drugs, and like I discussed, that neutropenia is a concern with palbociclib, while QTc prolongation and LFT monitoring with ribociclib, and diarrheas and LFT monitoring with abemaciclib. I'll skip this slide. Now, what is the real world evidence apart for the randomized trial? So if we see the real world evidence data, so that is the Flatiron data. It was a real world retrospective analysis of the electronic health records of postmenopausal women with hormone positive, HER2 negative MBC on pelbase plus letrozole versus letrozole alone in the first line. And more than 280 cancer clinics and 800 sites of care were involved, with over 2 million active patients on this combination. And if we see the propensity score matching or inverse probability treatment weighting matching analysis, the median real world PFS was 20.2 months as compared to 11.9 months in the letrozole alone arm. Again, the real world data also depicted the same advantage as the randomized trial data. And if we see the overall survival, also pelbase plus letrozole fared well as compared to letrozole alone, where overall survival was not reached as compared to 43.1 months in the letrozole alone arm. So this Flatiron data also concluded that first-line palbociclib plus letrozole is more effective than letrozole alone in a heterogeneous population among various patient subgroup. Now, if we talk of the real-world data, I mean, all ideal patients, apart for that, all other subgroup are also included, be it some comorbidity in the terms of GI, in the cardiac, and otherwise also, or metabolic abnormality. So real-world data is a real picture of how the drug fares in a common population as compared to the ideal setting of randomized trial. So this combination actually did fairly well and met the expectations in the real world also as compared to the randomized trial. Now, if we see the real world tumor response of pelbase plus letrozole versus letrozole for MBC, so this study again was a real world experience, and it basically compared the analysis of real world tumor response in patients with hormone positive, HER2 negative MBC who were treated in first line with pelbase plus letrozole versus the letrozole alone. And this study also concluded that this combination had an associated increased likelihood of tumor response compared to those treated with letrozole alone. So that after propensity score matching, it was 58.6% versus 39.1% respectively, with the odds ratio of 2.21, which was for which the p-value was highly statistically significant. And there was a generally consistent benefit of pelbase plus letrozole versus letrozole alone. It was seen seen in across all subgroups, including the visceral disease or bone-only metastasis with no significant interactions in the subgroup evaluated. And if we see the overall survival curves, the patients with one or more tumor response assessments, treatment with pelbase plus letrozole was associated with significantly longer median real-world overall survival versus letrozole alone. So a same conclusion like we discussed. Now, this is one all-important study of midline study. It basically studied the quality of life or the response assessed from the patients when the neutropenia was a side effect of pelbase and letrozole combination. So this study also evaluated the patient-reported outcomes, and it showed no association between neutropenia and decreased quality of life. That is why we do not use alone also the GCSF when the neutropenia occurs, because we know that quality of neutrophils is not hampered when the pelbase is used. It is only the number that is neutropenia is occurring. So this study also concluded that that quality of life was not hampered on this respective combination. If we see the Indian data with palbociclib, there are wonderful studies from the pioneer institutes like RGCI and the Regional Cancer Center Chennai and BLK. So this study was basically from RGCI and BLK, and 188 patients who were hormone positive, HER2 negative were assessed in this study, and all the premenopausal women like in randomized trials received the ovarian suppression or ovarian ablation along with this combination. And they also showed that median PFS was 20.2 months and in the first line and 12 months in the second line, with overall response rate of 80% in the first line and 47.9% in the second line. And this drug combination was well tolerable. And this real world data in Indian population also suggests the similar effectivity or effectiveness as compared to the randomized or the real world data outside of Indian context. And this is again a wonderful study from India and by Dr. Rodhan et al. And this also again propagated the same effectiveness and same results from the other Indian centers. Again, one more study from Cancer Institute Chennai, and this also was corroborative and showed little better, corroborated the same response rate. But however, in this study, so the patients the data analyzed showed that median PFS was 18 months, median OS was not reached, and 1 year PFS was 73.7 months. So results were a little lesser impressive than the other real world data. However, we know that when we enroll the patient in the real world setting, there are constraints that not the ideal patients or the ideal setting patients included in the randomized trials are included always in the real world also. So my take-home message is the CDK4/6 inhibitor should be the first-line treatment choice for all the hormone-positive HER2 MBC patients. There are 3 drugs available. The decision for individual drugs should be individualized as according to the patient profile and toxicity profile. And fulvestrant in combination with CDK4/6 inhibitor is reserved for the second line. And with this, I stand my talk here only, and thank you organizers for giving me this opportunity.
Dr. Chaudhary sir, you're there?
Yeah, I'm there. Thank you, Dr. Shefali. Dr. Vikas.
Thank you, Dr. Shefali ma'am. Would like to ask Dr. Advani sir and Dr. Chaudhary sir to give the concluding remarks so that we move to the next session. Thank you, Dr. Chaudhary sir and Dr. Advani sir for beautifully chairpersoning this session, sir.
Yeah, I think it's very clear from all the speakers that the combination of CDK4 and 6 inhibitors had a profound effect. In addition,
so we can't hear Dr. Advani. Sir, you will have to unmute yourself, sir.
It's unmuted. All right. It's unmuted.
There's some audio issue with Dr. Advani. Can't hear you. Can you hear, Vikas?
Sir, you need to speak closely to the mic, sir. Otherwise, yes, sir.
All the speakers have really clearly shown that addition of CDK4 and CDK6 inhibitors along with the endocrine therapy can be definitely superior in every aspect for such patients.
I think there are some issues with Dr. Advani's audio system. At least I'm not able to hear him.
Perfect.
Dr. Vikas, can we invite the next chairpersons, please?
Yes. So Dr. Advani sir's message was that CDK4/6 inhibitors combinations is definitely recommended for all patients in the metastatic breast cancer. And we thank Dr. Advani sir and Dr. Chaudhary sir for such a beautifully conducting sessions. Now I have the honor of inviting two of my best teachers across India, Dr. Hemant Malhotra, Professor Hemant Malhotra sir from Jaipur Mahatma Gandhi Hospital, and Dr. Ghansham Biswas down from South Bhubaneswar, Director Sparsh Hospitals. Both of them have been an inspiration, mentors, teachers, and torchbearers for the medical oncology fraternity across India. Without much ado, probably 365 days of conferences would be insufficient to create laudables about yours. Over to Professor Hemant Malhotra sir and Ghansham Biswas sir for the next TNBC session, sir.
Thank you, Dr. Vikas, and thank you, Dr. Meenu. And with the permission of my co-chair, my very good friend, Dr. Ghansham, I'd like to start with Charan Sparsh to my Guruji, Dr. Advani. And now we come to this session of triple negative breast cancer. And we have three excellent abstracts to be presented in this. Each presenter has 7 minutes. We're already about 10 odd minutes late. So my request is to please finish your presentation on time. Let's not waste any more time. I'll introduce the first speaker and then hand over to Dr. Ghansham Biswas to do the honors for the rest of the speakers. The first speaker is Dr. Chandra Gowda, and he's going to be talking to us about keynote 522, the use of the checkpoint inhibitor in the neoadjuvant setting. Over to you, Dr. Chandra Gowda.
Thank you, sir. Thank you, organizers, for giving me opportunity. I think my slides are visible already, right?
Yes, sir. Yes,
Yeah.
sir. Go ahead, sir.
So I'll be speaking on keynote 522 study of a neoadjuvant pembrolizumab plus chemotherapy with placebo versus plus chemotherapy, followed by adjuvant pembro for 6 months in early stage TNBC. It is just a reiteration of event-free survival sensitivity and a subgroup analysis. We already know about pathological CR data. So this was presented by a participant, and these were his disclosures. And to just an outset to set the example, the pembrolizumab showed an anti-tumor activity and a manageable safety profiles in a metastatic TNBC. So that is in the metastatic setting is approved as a first line. In the neoadjuvant pembro and chemotherapy, they showed a manageable safety and anti-tumor activity as per keynote 173 and IS-52. So this is the first prospective placebo-controlled phase 3 trial in a TNBC and in the neoadjuvant and adjuvant setting. The primary analysis showed that the neoadjuvant pembro plus chemo resulted in a significant delta of 13% increment in the PathCR rates. So neoadjuvant pembro chemo, all followed by adjuvant pembro, resulted in a statistically significant and clinically meaningful event-free survival at 18 months earlier. So based on this, the US FDA has already approved the pembro in this particular setting. Now this is a schema of 522 trial of the pembro. And the eligible patients were early T1C2 N1 N2 or T224 N0 N2 disease. They were also analyzed for PDL1, and there was periodiagnosed chemotherapy, this paclitaxel 12 weeks followed by 12 weeks of AC or EC with throughout pembrolizumab, which was only chemotherapy, followed by adjuvant 6 months of pembrolizumab, 3 weekly, 9 cycles of pembrolizumab versus placebo. So the stratification factors included nodal positive or negative, a tumor size, and the carboplatin schedule. So there were the stratification factors. So these are the study endpoints as for the primary endpoints, which are already seen, the PCR rates, the stringent PCR versus in situ in intensive to treat population by a local pathologist, and the EFS is assessed by investigator, And the secondary endpoints were various PCR definitions, the OS and the PCR, EFS, OS in PDL positive population, safety in all treated patients, and there are some exploratory analysis why this was not responded in some of the patients where where it did not result in path-CR. Are there any resistant factors in those biopsy specimens where we can do better in those subset where IO drug doesn't work in those? So that was some of the exploratory analysis which were performed. In the pre-specified sensitivity and subgroup analysis were performed to assess the robustness of the consistency of the primary EFS. Because it's an adjuvant trial, you need to know the robustness. Hence, this pre-specified sensitivity and subgroup analysis was performed. This is a summary of analysis populations in 2 cohorts, and if you can see the baseline characteristics in intensity of trait. So they're well matched between the node positive and negative. In the node positive, almost 50%, the node negative is 48. So also in the same stage 2 considered more of 3/4 of the patients versus stage 3, which is only 1/4. And the menopausal pre or postmenopausal between 50% in either arms. So also they also took the LDH into consideration, whether that plays a role. So that also they were also stratified according to that. So if you talk of a primary EFS analysis, the events were 15.7% in the pembro arm versus 23.8% in the placebo arm, with hazard of 0.63 and with a significant P of 0.00031. So we see at 3 years, the 84.5% of patients with pembro were event-free versus 76.8% in patients with placebo arm. So this is the primary and the sensitivity analysis definitions of EFS. So what is the definition of EFS that they're given? So either it is a local progression. This is the primary endpoint. The local, either the factors considered whether local progression or a local recurrence, distal progression or distal recurrence, death from any cause, a positive margin at the last surgery, a second primary cancer or a second primary breast cancer, a new anti-cancer therapy for a metastatic disease. These were the definitions of EFS that they have considered to calculate the EFS. So if you talk of EFS sensitivity analysis, the primary analysis, as already told, this was with a hazard of 0.63, and all analysis which I've just elucidated before or falling on the left side of the forest towards a pembro arm, favoring all the arms favor the pembro arm in this, thus indicating the robustness of this particular data in the neoadjuvant setting. So this an alternating censoring rules in terms whether they have received adjuvant capecitabine also was assessed. That was also significantly better in patients who have used pembrolizumab. So there also the positive margin at surgery was also taken into consideration. So that under that regard also it favors the usage of the pembrolizumab in this particular setting. So if you talk of EFS subgroup analysis by nodal status, the stage, the menopausal status, or an LDH. So all those factors favored the usage of pembrolizumab. So node positive had an incremental benefit. Stage 2 had a more benefit as they consisted of 3/4 of the population. If we talk of node positive, as I was talking about the subgroup, so the top one suggests that there's the node negative versus node positive. So the benefit is consistent whether it's node positive or node negative. So also the overall disease status as per the stage is concerned, it is consistent whether stage 2 or stage 3. So the benefit was seen on pembro arm. So if you talk for adverse events in combined phase, you can see both the bars of the green or the red, it almost matches with chemo versus addition of immunotherapy does not change much. So it is almost the same. So if you talk of the adjuvant phase of pembrolizumab, so there are some immune adverse events which are classical to pembrolizumab, though not much of grade 3/5 are seen. So that's around only 6% of the patients versus 3% of the patients. The serious events was in 3.2%. So this is what was in the adjuvant setting. So immune-related adverse events and infusional reactions were also definitely slightly more with the pembro arm, but nonetheless, the grade 3/5 are very, very less manageable. So this also in the adjuvant phase, depicting the same picture across neoadjuvant and adjuvant setting regarding the immune-related adverse event. To summarize, in the phase 3 KEYNOTE-522 trial, neoadjuvant pembro plus chemo followed by adjuvant pembro for 6 months resulted in statistically significant and clinically meaningful improvement in EFS. There is a pre-specified EFS sensitivity analysis that showed the robust treatment benefit of neoadjuvant pembro and chemo followed by adjuvant pembro in non-metastatic. This was generally consistent across a broad selection of pre-specified patient subgroups, including those with nodal as well as overall disease stage. And the safety was consistent with each regimen, and there were no new safety concerns. These further support that pembrolizumab plus platinum-containing neoadjuvant chemotherapy followed by adjuvant pembro after surgery as a new standard of care treatment in patients with high-risk early TNBC. With that, I end my talk, and thank you very much for giving me the opportunity.
So thank you, Dr. Chandragauda, for that talk. And so good afternoon, everybody. Respected Chairperson, Dr. Hemant Malhotra, sir. And thank you, Vikas, for those kind words, and Minu, madam. So now we move from neoadjuvant setting to metastatic TNBC in the first line. So moving from keynote 522 to keynote 355. So good friend of us from the neighboring state, Dr. Vivek from Narayana. So he'll talk on 355 in a metastatic TNBC. So Vivek, all yours.
Thank you, Dr. Vikas and the organizers for giving me this opportunity. So straight ahead, talking about the so the efficacy of pembrolizumab plus chemotherapy versus placebo plus chemotherapy as per the keynote 355 study in metastatic or inoperable locally recurrent triple negative breast cancers in first line, focusing on the subgroup analysis as per the PDL1.
Vivek, we are not able to see your slides, so please make it a slideshow.
Yeah, sir, it is in slideshow only.
I don't think so. We are only on the first slide only.
And you have to reshare the slide and you have to select the entire screen option.
Okay, sir, just.
Instead of sharing just the slide, share your entire screen.
Just a second. Yeah, I think now is it visible?
Yes, sir.
Yes, yes, please go ahead.
And you can use the mouse or touchpad. Yeah, fine, sir.
Yeah, thank you. Sorry for the glitch. So, as already said, pembrolizumab monotherapy has shown a great clinical activity in few of the patients of higher PDL1 expression in metastatic TNBC. Dr. Chandragauda just talked about pembrolizumab plus chemotherapy data in neoadjuvant setting and how it improved the EFS as compared to chemotherapy alone. And now we have the keynote 355, which was presented last year. So let us look at this data. Keynote 355 in this study, patients of de novo metastatic or locally recurrent inoperable triple negative breast cancers were taken. Important to note is that patients were either naive or had completed a curative treatment more than 6 months prior to first recurrence. And active CNS metastasis patients were not taken. Patients were randomized 2:1 to either of pembrolizumab plus chemotherapy versus placebo plus chemotherapy. And the patients were stratified as per the type of chemotherapy, which was either paclitaxel or nab-paclitaxel or gemcitabine carboplatin. And what was the PDL1 expression? More than 1 CPS or less than 1? And what was the prior treatment with the same class of chemotherapy in the neoadjuvant or adjuvant setting? The primary endpoint was PFS in the PDL1 subgroup, PFS of CPS greater than equal to 10, CPS greater than equal to 1 and intention to treat, as well as the OS in the similar, as well as the secondary endpoints were overall response rate, duration of response, DCR and safety. Now, in this analysis, the outcome is focused on the additional CPS cutoffs. So this was the randomization, and 566 patients were there in the Pembro plus chemo arm, and we can see patients were followed up for 44 good months, and there are around 10 to 20% patients who completed the entire treatment, that is 35 cycle, that is almost 2 years of Pembro plus chemo, after which they were discontinued from chemo. So what we can see is that almost 75% patients were CPS more than 1, and CPS less than 1 were 25%, and we had around 25% patients which were more than CPS 20 also. So these are the baseline characteristics which were similar in both the arms, and what is to note is that the median age was 53, almost probably 8 years, 9 years more as compared to what we see in India. And this is the overall survival final analysis. We can see that in the subgroup of CPS more than equal to 10, there was a statistically significant improvement in the median overall survival from 16 months to 23 months. So a good 7 months gain, which was very good. Similarly, the gain was not so much, and PDL1 subgroup of CPS more than equal to 1 or in the intention to treat population. So the main benefit was in the subgroup of CPS more than equal to 10. And when you look at the individual CPS subgroups, what we see is that the PDL1 CPS 10 to 9 and the PDL1 CPS more than 20 are benefiting with a median OS of 20.3, which is increasing to 24 months in the CPS more than equal to 20. This is the hazard, and we can see that clearly the two below graphs, that is CPS more than 10 to 19 and CPS more than equal to 20, we can see the clear separation of graphs and which are not there in the above groups. Similarly, in the PFS also, we can see similar results, almost a 4-month gain of PFS in the CPS more than equal to 10, 2 months gain of PFS in both the intention to treat and CPS more than equal to 1, but which was not so significant. The hazard is 0.66 in CPS more than equal to 10. And similarly, here also we can see that the delta is towards the CPS 10 to 19 and CPS more than equal to 20. Similarly, shown in the graphs. If you look at the adverse events, what we can see is that there are no major adverse event difference between the two classes so far as the hematologic toxicities and other non-hematologic toxicities are concerned. When you look at the immune-mediated adverse events as a class, obviously Pembro plus chemo arm had more hypothyroidism and hyperthyroidism and 2% pneumonitis. So the conclusion is clear: Pembro plus chemo resulted in a statistically significant and clinically meaningful improvement in PFS and OS versus chemotherapy alone for first-line treatment of PDL1 CPS more than 10 metastatic TNBC, and it is a reasonable cutoff to define the population. Safety profile was consistent, and this result clearly provides good support for use of pembrolizumab in this setting. Now, what are the discussion points? So first of all, PDL1 CPS more than 1 as 75% patients and more than 10 in 35 to 40% patients. Well, do we get such high PDL1 positivity in India? Well, not in my clinical practice. And why it is so? Whether does it matter we are doing it by SP142, SP263, 22C3, whether it is because of the younger age of our patients, whether it is because of our pathologists reporting and training in this thing, whether it is because of the quality of blocks and tissue handling, whether it is because of racial differences, we are yet to learn it. But definitely, we do not get such a population of high PDL1 in our TNBCs. What about the BRCA status? Well, BRCA is another important marker that we definitely do in our patients, but this was not included as a stratification factor or documented in this trial, neither in IM Passion 130, 131. So probably, I feel that there is a benefit irrespective of the BRCA status. And whether this data is applicable in later lines, what we don't use it in the first line. So we don't know, but I think it should be at least in the second line if the patients have good PS1, and they're unlikely to be a good benefit if you are using it in very late lines. Another important discussion is Atezo versus Pembro. Well, IM Passion 130, Atezo plus nab-pacli, it showed a great benefit. There was an accelerated approval by FDA, there was a 2.5 month PFS gain, a 7-month OS gain similarly in patients with PDL1 more than equal to 1. But in IM Passion 131, we saw that atezo plus Pacli, there was no PFS gain or OS gain even in the PDL1 positive subset. And the FDA label for atezo in TNBC was withdrawn by Roche in the US. And why did atezo fail in IM Passion 131 but worked in 130? And Pembro is working in Keynote 355. So are the atezo and Pembro very different? I don't think so, probably not. But does it matter whether nab-paclitaxel was used in 130 and paclitaxel was used in 131? Probably not. But is the patient selection different? I think that is the main key. The assay to define PDL1 positivity, that is the SP142 with IC more than 1, is shown by multiple studies to be non-reproducible. And there may be a chance that they picked up the correct patients in IM Passion 130, but in IM Passion 131, they could not pick up the correct patients. So probably it is the way we look at the. So my take is that in metastatic TNBC, we should do a PDL1 DACO 22C3 and a BRCA at baseline at least. Patient selection is the key so far as immunotherapy is concerned. We do not get such patients very frequently in our clinic who have CPS more than equal to 10. But if patients are in good PS, there are no brain mets, then I would be very happy to consider either Pacli or nab-pacli plus pembrolizumab in first line. BRCA status and the line of treatment probably should not matter, and we can use gem-carbo or PARP inhibitors in second line or vice versa with Pembro plus chemo. And Pembro, I think, would be preferred over atezo in view of the consistent data. Easily done companion test 22C3, which we have experience of as against SP142, with more reliability and reproducibility, and longer follow-up data of 44 months with pembrolizumab. So with this, I thank you all for patient listening. Thank you.
Thank you, Vivek. So that was a great takeaways. And so before we move to HER2 positive, so we have one more talk in the triple negative setting. So it is by Dr. Rakesh Pinniti from Hyderabad. So another in the neoadjuvant setting, the Pearl trial. So preoperative Pembro with radiation in the early stage TNBC. Dr. Rakesh.
Good afternoon to all. Thank you, organizers, for this opportunity. So again, pembrolizumab in triple-negative breast cancer is showing up a lot more questions than answers. And I would like to reiterate the last two speakers for the excellent presentations. I would like to continue the discussion with this Pearl trial, basically preoperative pembrolizumab with the radiation therapy in early stage triple-negative breast cancers, presented by Professor MacArthur. So coming to the background of the study, so we all know that triple-negative breast cancer is at a higher risk of early relapses, and if we believe that pathological complete response are a surrogate for overall outcomes, then the focus has been to improve the pathological response in the past few years. Either it could be addition of carboplatin or addition of radiotherapy or addition of pembrolizumab. Everything has been a focus of improving the pathological complete response. The traditional neoadjuvant chemotherapy has a pathological complete response of nearly around 30-50%. Again, addition of pembrolizumab, as seen in the Keynote 522, has shown to improve pathological complete response by nearly 7.5%. It also shown to improve event-free survival. However, this improvement in the event-free survival, the relative contribution of neoadjuvant therapy versus the adjuvant maintenance therapy is not as of now clear. However, it has become a standard of care based upon the Keynote 522. The US FDA has approved pembrolizumab as a neoadjuvant strategy. Again, radiotherapy is known to be immunogenic. It can potentiate the local tumor destruction and demonstrates synergy with checkpoint inhibitors in preclinical models. Even in the metastatic setting, it has shown to have a synergy and an overall response rate nearly about 20%. Again, when used as a standalone treatment, neoadjuvant radiotherapy is safe and can confer modest pathological responses of nearly 40%. So this is a clinical trial that is a single institution phase 1b/2 study. They enrolled operable triple-negative breast cancers or hormone receptor less than 10%, and those patients were eligible for adjuvant therapy. Again, pembrolizumab was given preoperatively. There are 2 cycles of pembrolizumab, as you can see here. These are given every 3 weekly, and there are biopsies which were done prior to the pembrolizumab. There was biopsy that is done prior to the radiotherapy as well. And after the 2 cycles of pembrolizumab, 3 weeks delay, they undergo neoadjuvant chemotherapy, and the schedule of neoadjuvant chemotherapy is physician choice. and subsequently they complete the surgery and radiotherapy. So there are exploratory lab-based analysis in this clinical trial. They have research bloods and tumor biopsies. As I said, 2 times the biopsies were done. Again, tumor-infiltrating lymphocytes were also assessed by the blinded pathologist. PDL1 in this was assessed by DACO 22C3 PharmaDX staining procedures, and combined positive score has been reported. Again, primary objectives of this study is that to assess the safety and tolerability, which is defined by the number of patients who do not require a delay in standard of care neoadjuvant chemotherapy or surgery. There are exploratory analyses like changes in PDL1 and tumor-infiltrating lymphocytes, and secondary objectives are describing the pathological complete response and safety and toxicity up to 1 year of study enrollment. So coming to the results directly, we see that there are 50 patients who were enrolled between December 2017 and April 2021, and pathological complete response was in 56%. Again, major pathological response was noted in 74%. Again, in patients who had a biopsy-proven lymph node, the lymph node was negative at the time of surgery in 76%, and only micrometastatic in 6%, making 82% patients who are essentially node negative, thereby reducing their chance of recurrences. So coming to the safety, no patient experienced a clinically significant delay in initiating neoadjuvant chemotherapy. However, 12% did not complete the planned course of standard of care neoadjuvant chemotherapy. 12% in says 6 out of 50 patients. Out of these 6 patients, at least 4 patients had a delay because of the immunotherapy-related complications. There are 4 patients with grade 3 toxicities that can be attributed to pembrolizumab, hyponatremia, colitis, adrenal insufficiency, and pneumonitis. And there are 3 patients with neutropenia attributed to neoadjuvant chemotherapy. So this is the PDL1 analysis. Basically, again, this 86% PDL1 positive is some sort of a, I cannot explain this because whenever I check the PDL1 in my patients, I tend to see only in 20 to 30%. But if you see the Western data, most of them are having a high PDL1 percentage positivity. Again, baseline PDL1 expression was not associated with treatment response, and PDL1 status after cycle 1 and also after cycle 2 improved compared to that of baseline. Again, PDL1 status after cycle 1 associated with the treatment responses. As we see here, baseline 86% compared to 93% and 90% after the pembrolizumab and radiotherapy. And if you see after cycle 1, only 23% patients had a major pathological response. This is TIL analysis, tumor-infiltrating lymphocytes by blinded pathologists. Again, baseline TILs was not associated with treatment responses. Again, there was no significant increase in TILs after cycle 1 pembrolizumab. However, in subset of patients who had a low level of TILs at baseline, there was an increase in the levels of TILs after the chemotherapy, after the immunotherapy cycle 1. Again, there was a significant decrease in TILs after the pembro and radiotherapy. So there is significant implications of timing of radiotherapy, timing of immunotherapy compared to that of chemotherapy. So there is a science which is still not understood yet. So these are the final conclusions. This appears to be the first curative intent clinical trial that has combined preoperative immune checkpoint inhibitors with radiotherapy for the treatment of triple-negative breast cancers. It is appearing that it is safe and feasible. Again, 56% of the patients achieve pathological complete response, which is similar to the control arm of the Keynote 522. However, the investigators have clearly noted here that only 1/3 of the study participants actually have taken the stipulated neoadjuvant chemotherapy of Keynote 522, which is a dose which is AC followed by taxane carboplatin. So if you can reduce the intensity of, or at least in patients who cannot tolerate neoadjuvant chemotherapy in a dose-dense manner, or carboplatin cannot be delivered, there appears to be a role for a radiotherapy and as well as combination of radiotherapy and immunotherapy to maintain the pathological complete response of that 50 to 60%. Again, there is a significant reduction in patients who had node negative increase in patients who had node negative disease. Nearly 3/4 of patients are who had node positive disease at baseline became node negative after the application of chemotherapy, immunotherapy, and radiotherapy. Again, these are all exploratory analyses, and the time determined long-term impact of this intervention is not yet known. And there are a requirement of large randomized studies of using the neoadjuvant chemotherapy, immune checkpoint inhibitors in combination with radiotherapy and timing of radiotherapy. These all have to be confirmed. Thank you very much.
So thank you, Dr. Rakesh. So we understand that TNBC in last 1 decade, from no hope to there is a hope. So lots of improvement, lots of insights into TNBC. So moving gears from TNBC to HER2 positive, though initially it was planned to have Dr. Arya. So now we'll invite Dr. Minu Madam, so from Max Patparganj, senior oncologist, and the organizing secretary of this meeting. So Minu madam, all yours. So this is sponsored by Roche. So she will talk on improving treatment outcomes in HER2 positive early breast cancer.
So thank you, Dr. Kansham. Let me share the screen first.
Ma'am, you can open the presentation first and then you click on the share screen button.
So is my screen visible?
No, ma'am. Aru, do we have the backup slides?
Yeah, I think Taru has the backup slides.
Aru, do we have the backup slides? Can we run? Yeah. So, ma'am, your slides are there. So you just have to say next. So you have 15 minutes to, do the needful. Ma'am, we have already shared the screen. Mino, ma'am?
Yeah.
Yeah.
So thanks, Rosh, for the opportunity. And let's go to the topic straight away. And today's buzzword, actually what we are talking about is tailoring therapy. And let's see how we can tailor therapy in HER2 positive disease, and especially HER2 positive residual disease after neoadjuvant chemotherapy. Can I have the next slide, please? Next. So there are many points during the management of HER2 positive early breast cancer which help us in tailoring treatment accordingly, or how to decide therapy. Yes, at diagnosis, what is the size of the tumor, whether the lymph nodes are involved or not, what is the grade of the tumor, all these factors, hormone receptor positive, and then definitely, yes, HER2 positive negative status, to decide whether in today's date surgery upfront or neoadjuvant therapy upfront. If we go for neoadjuvant therapy, then after surgery, yes, the pathological assessment will help me further to make an important few decisions. What should be the next adjuvant therapy? Can I have the next slide? Next, please. So yes, we are giving neoadjuvant therapy, but we know that in spite of the best of the neoadjuvant therapy and double blockade also, there will be a significant portion of patients who will have residual disease. So prior to the Catherine trial, what we were doing is, irrespective of NACT or not, all these patients will go for 18 cycles of blockade, either with a single or with a double agent. Next, please. But now that we know that in spite of the best of neoadjuvant therapy, there will be residual disease, there may be residual disease, not all of these patients will achieve a pathological complete response. So what happens in those patients which do not have a pathological complete response? Next, please. Needless to say that the outcomes of these patients are poor. We have enough data by now. And again, as high as from across the various studies, whether it is Neosphere, Trafina, all these neoadjuvant studies, we know that approximately 50% of the patients, in spite of receiving the dual blockade in the neoadjuvant therapy, may not have a pathological complete response. Next. And in this subgroup of patients who do not receive the pathological complete response, the outcomes are much more, and there is a vast unmet need how we can improve the responses or improve the disease-free survival and the overall survival. Next, please. So this is what, can we do anything else to improve these patients, to improve and decrease the risk of recurrence in this group of patients? So we have data from the CREATEX trial that was for triple negative breast cancer, where therapy was tailored after neoadjuvant therapy and possibly some improvement in disease-free recurrence. And what do we do for the here in the HER2 positive subgroup? Again, next please. So that is what, after we will see, we will discuss this slide again, how the Catherine has impacted our clinical decision making. After neoadjuvant therapy, patients go for surgery and residual and assessment of pathological complete response. If there is pathological complete response, then it is worthwhile to continue the targeted therapy, whatever we have been using previously, or even single targeted therapy to complete 18 cycles. But in the absence of pathological complete response, that makes a lot of sense to change treatment or upgrade the treatment or tailor treatment to TDM1 or Ketsela for next 14 cycles in the adjuvant setting. Next, please. So again, we had evidence from metastatic setting that TDM1 has shown activity and shown activity in patients who have progressed beyond trastuzumab and and in the resistant subgroup also. And extrapolation of that data was something which was used in this study, and also data from CREATEX. Next, please. So this was the Catherine basic study design. Inclusion criteria was histologically proven invasive breast cancer patients, HER2 positive, T1A and above. T1A and T1B were not included. So T1A upwards were included, irrespective of lymph node positive disease and early breast cancer. And these patients should have received minimum of 6 cycles of chemotherapy. Randomization was done after surgery. A patient underwent surgery, and all those patients who has had residual invasive tumor in the breast were randomized in the ratio of 1:1, and one arm received trastuzumab 6 mg per kg, 14 cycles, and the other arm received Ketsela 3.6 mg per kg for 14 cycles. So we see that in this study they were able to enroll approximately 1400 odd patients, and the stratification factors were further apart from the inoperable or operable clinical stage, hormone receptor positivity, and also the whether it was in the neoadjuvant setting, a single blockade or double blockade was used. The next, please. The primary endpoint was, can I have the next slide? So the primary endpoints that was studied was the invasive disease-free survival, and the secondary endpoint was in the definition of invasive disease-free survival. For the secondary endpoint, they also included the second primary non-breast cancer tumors. Apart from that, overall survival and safety profile also. Next, please. So the inclusion criteria, as I already said, patients should have received minimum of 6 cycles of chemotherapy and minimum of 9 weeks of trastuzumab, or 8 weeks of trastuzumab in cases of dose-dense therapy, irrespective of whether a patient received single blockade or double blockade therapy, and the hormone receptor status should be known for all. This was the HER2 positive subgroup, and exclusion criteria as elicited. Can I go to the next slide, please? So let us see the randomization, since it was 1:1 randomization. So we had 740 odd patients in either arm. And next, please. So we will be rushing these slides for lack of time. Next, please. So looking at the stratification factors, we are looking at the two subgroups, the arm on trastuzumab and the other on TDM1, 743 patients in either arm. And if you see, all the factors were very well matched. Whether inoperable at presentation or operable at presentation, hormone receptor positive, negative, whether they had received single agent or double agent, and pathological node positive or node negative. Knowing that majority of the patients who have hormone receptor positive disease do not receive that well pathological CR in HER2 positive broader group, we can see, having a closer look, that even the positivity rate of hormone receptor positive were well matched across the two subgroups. Further, next please. Again, the rest, all of the factors, whether age, race, and region were well matched. Next, please. And this was after neoadjuvant therapy. So more than 40% of the patient had a very small amount of residual invasive disease. So we can see at least there were almost 40% of the patient in either arm who had either just the tumor in situ or a very small negligible residual disease, even micro disease after neoadjuvant therapy. Next, please. And the prior therapy, anthracyclines versus not anthracyclines, single versus double, were also quite matched. And approximately 18% of the patient had received in the neoadjuvant setting double blockade. Next, please. So this is what Catherine showed us. It met its primary endpoint. It had reduced the risk of an invasive disease-free survival by as high as 50% compared to trastuzumab alone at a median follow-up approximately 41 months. So hazards ratio 0.50, a very, very impressive hazards ratio as far as oncology is concerned. 50% reduction in the risk of recurrence of death, and an absolute benefit of 3-year invasive disease-free survival from 77% to 88.3%. Can I have the next, please? And in all across all the stratification subgroups, whether it was inoperable at presentation or operable at presentation, irrespective of the hormone receptor status and other factors, we can see in the forest plot that the things were in favor of Kadcyla only. Can we have further? Next slide, please. And especially I'll want people to pay attention to this subgroup. The benefits of TDM1 were consistent irrespective of the tumor size and nodal status at surgery. So even those patients who had a very small residual disease, T1 situ also, or less than equal to 1 centimeter and node negative residual disease also, they benefited by addition of TDM1 in the adjuvant setting. Next, please. Next. So yes, the OS data is early, but the trend is towards the same only, and the hazards ratio so far is quite encouraging. Can we have the next slide? And this I have already said. Can we have the next slide? So in this subgroup, in the inclusion criteria in the Catherine study, there was a small group of patients who had a very small tumor to begin with. That was almost 77 patients. So what does Catherine tell us? That even in this small group of patients in such small tumors, there will be a risk of residual disease. So there was some residual disease in some of them. And yes, this was also the group which benefited after the addition of TDM1. Next, please. Next. So irrespective of prior neoadjuvant therapy, whether we used a single monoclonal antibody or we used the double blockade, the the ratio of benefit was almost the same in both the arms. So we did find numerically better outcomes for those who had received the double blockade, but the ratio of benefit was the same. So irrespective of whatever targeted therapies we are using in the neoadjuvant therapy, the benefit remained. Going further, next please. Next. And another very important point that was discussed was the competing risk. Since there was a substantial reduction in the incidence of non-CNS recurrences, so it was thought that possibly the likelihood of CNS recurrence as the first event may be more with the TDM arm. But however, what does the data tell us? The data tells us that the cumulative incidence of CNS recurrences was almost the same in either arm, whether the patient was on trastuzumab or TDM1. However, there was a longer time to CNS recurrence in the Kadcyla arm. Yes, CNS recurrence was the only recurrence in the Kadcyla arm in a higher proportion of patients, but this did not. Can I have the next slide? But this did not compromise the overall survival. So when we looked at the overall survival following the CNS recurrence, no evidence was there that the numerically higher rate of CNS recurrence, which as a first event in the Kadcyla arm, had a detrimental impact on overall survival. Next, please.
Ma'am, you have last 2 minutes to conclude, please.
Yeah, I'm just concluding. Next, please. So we can rush through these slides. Irrespective of the adjuvant radiation and hormonal therapy, the benefits remain. Next, please. Next. I think next we will come to the summary. Safety, next only. There was a higher proportion of patients who discontinued therapy in the TDM arm. However, these adverse events, next please, were more to do with the lab abnormalities. So majority of the adverse events were low platelet or just the clinical lab abnormalities, LFTs deranged. Can I have the next slide? And this is what it was. So majority were the lab abnormalities, and majority of these side effects were resolved also. Something like peripheral sensory neuropathy resolved, and cardiac events were almost the same in the either or arm. Can we have the next? Next. So how do we manage HER2 positive disease? What does Catherine teach us? So all those patients who are more than equal to 2 centimeter node positive, neoadjuvant therapy is the way to go. And post neoadjuvant therapy after surgery, looking for pathological complete response. Any residual disease is residual disease, even if it is a microscopic residual disease. And there is the benefit of changing therapy in that subgroup of patient. So changing to TDM1 or Kadcyla for next 14 cycles, we have an advantage of decreasing the recurrence rate by as high as to the tune of 50%. Can we have the next? So the last. So what do the guidelines say? So all the guidelines, whether it is NCCN, ESMO, St. Gallen or AGO guidelines, they say that the presence of any amount of residual disease should help us in making the decision to change treatment or upgrade the treatment in the adjuvant setting. Can we have the next? Next. So approved both by EMA and FDA. And yes, Catherine has now introduced a new decision point in HER2 positive early breast cancer, and any patient with any residual disease should receive TDM1 in the adjuvant setting 14 cycles. And another important point that has been brought forward is that in spite of double blockade, there may be still a risk of residual disease, and in spite of achieving PCR also, there might still be a risk of relapse, albeit a smaller risk. And continuation of targeted therapy should continue even in those subgroup of patients. So this is what were the key messages. This is the opportunity where we have a curative intent, and because we have a curative intent, we should keep our best foot forward. And any residual disease, we should try to upgrade the therapy to TDM1. It will decrease the recurrence by as high as 50%. So with that, I say thank you.
So thank you very much, Dr. Meenu, and we'll quickly move on to the next presentation. This is another sponsored session, and this is sponsored by AstraZeneca.
Sir, sorry to interrupt. Hemant sir, sorry to interrupt. Actually, we missed Dr. Devrat presentations because Dr. Meenu was to go early. So we have now Dr. Devrat Arya's presentation.
Okay, sure. So we'll move back a step. Again, the session sponsored by Roche, and we'll talk about neoadjuvant treatment of HER2 positive early breast cancer. And the speaker is Dr. Devrat Arya. And Devrat, you have 15 minutes if my printout is correct.
Yes, sir.
Okay, all over to you, Dr. Devrat.
Hello, everyone, and thank you, organizers, for giving me this opportunity to present here my talk today on the neoadjuvant treatment of HER2 positive breast cancers. And I hope my slides are visible and I am clearly audible.
Very much so.
So I think the aim today is to, over the next 15 minutes, cover the role of neoadjuvant treatment of HER2/neu positive early breast cancer. What are the evidence and what are the clinical considerations? Now, we know that HER2/neu positive breast cancer is a biologically complex disease. We know that there are different ways to check for HER2/neu, IHC and FISH being the dominant ways that we check it. We know that clinically the disease is more aggressive. We know there are microscopic differences in the disease as well as differences in the DNA, the genomic expression level as well. When we talk about neoadjuvant therapy broadly in breast cancer, I think initially we began with giving systemic therapy for those patients who had inoperable locally advanced breast cancer to enable surgery. But I think increasingly from an operable breast cancer, from an inoperable breast cancer, we're moving to operable breast cancers. Also simply because of the fact that in the higher risk setting, particularly in HER2/neu positive setting, the combination of chemotherapy along with target therapies and occasional cases, endocrine therapy and target therapy is actually improving outcomes. So neoadjuvant therapy, other than making an inoperable tumor operable, which was the traditional indication for NACT, is actually even in an operable setting, ensuring that more and more women become candidates for BCS by able to shrink the tumor prior to surgery. And this also ensures that the complications of surgery are lesser. There's a reduced need for revision of surgery in case there's residual disease. I think one of the key endpoints of any neoadjuvant treatment is also PATCR, which is pathological complete response. And we'll discuss later in the slide how pathological complete response and achievement of PATCR is actually a predictive of improvement in outcomes. And increasingly with the advent of data like Catherine, we are able to provide response adjusted therapy. So those women who are unable to achieve PATCR and therefore who are associated with worse long-term outcomes, there's an option of switching to or escalating to TDM1 in order to improve their outcomes. And I think that's an important endpoint. So when you talk about neoadjuvant therapy response evaluation, while traditionally in oncology and traditionally in breast cancer, we would look at local control rates, disease-free survival and overall survival. I think the major endpoint, which is also now FDA approved, is the PATCR rates. When newer therapies are evaluated in a neoadjuvant setting. So as a clinician, I am not only looking at response, but also pathological complete response. Obviously, there's a lot of interest around other ways of assessing response, molecular like Ki-67 circulatory tumor cells, or imaging like response on a PET or MRI. But as of now, pathological CR is considered a significant endpoint and is also used as a surrogate for long-term outcomes. So what is pathological complete response? I think there have been different ways of describing pathological complete response, but traditionally the most commonly accepted definition is in the breast absence of invasive cancer or irrespective of ductal carcinoma in situ. So that's the PATCR in breast, but the total PCR is when we say that there's no residual invasive tumor in either the breast or the node. So this definition allows for ductal carcinoma in situ being present in the breast. However, if you have a YPT0/IS or a YTN0, that is determined to be a pathological complete response. So let's quickly discuss some of the pivotal neoadjuvant clinical trials in the HER2/neu setting. I think we know in the early 2000s, trastuzumab made a difference to how we treated all our patients with HER2/neu positive disease. We saw it improved outcomes first in metastatic setting, then in adjuvant setting. NOHA was a study which looked at the role of trastuzumab in a neoadjuvant setting where patients who had HER2/neu positive disease, these were predominantly stage 3. Remember, these are early or mid 2000s. These patients were randomized to receive standard chemotherapy, which was anthracycline or paclitaxel, followed by CMF, with or without trastuzumab. And these patients then underwent surgery. And then those patients who received trastuzumab could go on to receive 1 year of trastuzumab. And what did the addition of trastuzumab do? I think neoadjuvant trastuzumab significantly increased PATCR rates. So the PATCR rates in the entire population improved from 26.3% for the chemotherapy alone arm to actually 65.2% for the trastuzumab plus chemotherapy alone. I mean, I think we've seen that not only in the NOAA study, but in fact in the subsequent meta-analysis, that the addition of trastuzumab has led to an improvement in PATCR, which has varied from anywhere between 15 to 20% across studies. Again, back to NOAA study, also in the long-term results, we saw that the event-free survival for those patients who received trastuzumab was much better compared to those who received chemotherapy alone. And there was also a trend towards improvement in overall survival for those patients who received trastuzumab compared to those who received chemotherapy alone without any trastuzumab. And I think on the basis of this, trastuzumab with standard chemotherapy became the go-to option for most of our patients. We know that with this combination across different trials, you would achieve a PATCR rate of around 45 to 50%. And that became the benchmark that we worked on. Now, obviously, there has been a lot of interest around how can we achieve this PATCR rates? How do we improve the PATCR rates from the usual 40, 45, 50% to much higher than that? And there's been a lot of interest around this monoclonal, which is pertuzumab. I know, as you all know, this is an antibody which works differently from trastuzumab, does a lot of things, predominantly preventing HER2, HER3 dimerization. We know that in metastatic setting, it improved outcomes, and therefore there's also a lot of interest in neoadjuvant studies. Preclinical setting showed that the addition of pertuzumab led to improved anti-tumor activity, and there were a lot of studies. And one of the studies that we often quote is the NEOSPHERE study, which was a randomized multi-center open-label phase 2 study, which included patients with HER2-neu positive patients with operable or locally advanced disease or inflammatory breast cancer, and also included some patients who are chemo-naive, primary tumors more than 2 centimeters. These are the usual patients that we in our real-world practices would start neoadjuvant therapy on. And the patients were then randomized to receive either docetaxel with trastuzumab, docetaxel trastuzumab, or pertuzumab, or interestingly, docetaxel pertuzumab. And there was also this chemotherapy-free arm, which is trastuzumab and pertuzumab. And this was given in the standard doses. And patients received 4 cycles of this therapy. And all the patients subsequently had surgery and then received anthracycline-based therapy thereafter. The primary endpoint was PCR rates in the breast, but we're also looking at secondary endpoints, which was PCR, the standard definition in breast and nodes, clinical response, time to clinical response, and BCS rates and safety. So what were the results? I think very interestingly, when you look at the PCR rate in breast, the highest responses were seen in the chemo docetaxel plus trastuzumab and pertuzumab. And so the PCR rates of 45.8%, so nearly 49% in the triple drug trastuzumab, pertuzumab, and docetaxel arm, which compared favorably to the docetaxel and trastuzumab arm, which was 29%, which otherwise at that time was the standard of care. And these responses sat much better than docetaxel pertuzumab, and also the chemo-free arm, which showed a response rate of about 17%. So clearly, the addition of pertuzumab improved PATCR rates. There's also this analysis of the long-term outcomes, the 5-year follow-up and PFS rates for those patients who did achieve a PATCR in this study. And clearly, we see that those patients who did achieve a PATCR, the hazard ratio for recurrence was 0.54 in those patients who did achieve a PATCR. So clearly, even in this study, you can see that achieving PATCR is important, associated with long-term outcomes. And the phase 2 study showed that when pertuzumab was added to chemo and trastuzumab, it led to the highest PCR rates. We also then had the TRIFINA study, which is actually a phase 2 study of trastuzumab and pertuzumab in the neoadjuvant setting. So patients who had HER2-neu positive breast cancer were randomized to receive trastuzumab, pertuzumab, along with FVC cycles 1, 2, 3, and then docetaxel cycle 4 to 6. So this was a study which combined anti-HER2-neu with FEC in the arm 1. Arm 2 was FEC cycles 1, 2, 3, and then docetaxel, trastuzumab, pertuzumab cycle 4 to 6. And then we had the third arm, which is the TCHP arm, the docetaxel, carboplatin, trastuzumab, and pertuzumab. And the patients were then supposed to have surgery, and then trastuzumab could be completed for 1 year. So this was predominantly a cardiac safety study. So the primary endpoint was safety and tolerability of the neoadjuvant regimen. cardiac safety, symptomatic decline in the left ventricular function, and then asymptomatic declines as well. And the secondary endpoints were PCR and clinical response. So what were the PCR rates? And I think we should focus on the middle pillar. So when you look at the PCR rates for the FEC PH followed by docetaxel PH arm, the PCR rates were 56%, very similar to the FEC alone followed by docetaxel, trastuzumab, pertuzumab, which was 54% again. And then when you look at the TCHP arm, the PCR rates were 63%. So clearly this study showing that irrespective of the chemotherapy regimen, the addition of trastuzumab and pertuzumab provided a clinical benefit which was very consistent, and to some this would also suggest, again, this was not the primary endpoint of this study. It did suggest that the improvement was similar even if you had an anthracycline free arm. Now when you look at the data from a HR positive and HR negative setting, again clearly we would have more PCR rates in the HR negative setting, but look at the TCHP arm in HR negative setting, PCR rates are about 83.8%, which are very high, and even in the FEC THP arm, the FEC HP THP arm rather, the PCR rates in the HR negative settings are 79%. So fairly high PCR rates, and therefore these two studies together showing that the addition of pertuzumab is actually associated with improvement in PCR rates, and that's what we've been trying to look at. There's been an interest around other dual anti-HER2s, and in fact there's also been an interest around chemo-free regimens. We know we looked at the data from lapatinib. We do know that while we have had contradictory results with the addition of lapatinib in a non-metastatic setting, we've had studies where lapatinib when added to trastuzumab improved not only PCR rates but also outcomes. But given the fact that this is a toxic regimen, or rather a difficult regimen in terms of side effects and the contradictory results from various studies, this has failed to become a standard of care. We also have a small subset of patients who would either refuse to take chemotherapy or who would actually not be fit for chemotherapy and yet would need some sort of neoadjuvant chemotherapy. And there's been a lot of interest around whether a chemo-free regimen can improve outcomes. So we had the Neosphere chemo-free arm, the pertuzumab trastuzumab arm. We clearly see that 12 weeks of dual anti-HER2 led to a PCR rates which was 16.8%, while 6% PCR rates in HR positive setting. Similarly, TBCRC006 looked at a combination of lapatinib plus trastuzumab along with endocrine therapy if needed. PCR rates were 27%. Higher in the HR negative arm compared to HR positive arm. Pamela looked at lapatinib plus trastuzumab again for 18 weeks and a PCR rates of 30%. And then the TBCRC 023 study, which looked at 12 versus 18 weeks of lapatinib trastuzumab with or without endocrine therapy for HR positive patients. And clearly, while the longer therapy benefited the HR positive population, did not benefit the HR negative population. So clearly they are associated with some PAT-CRs, but when you look at the chemotherapy plus anti-HER2 PAT-CR rates, they are much higher, and therefore there's no doubt that chemo plus trastuzumab and pertuzumab now is the regimen that is associated with the highest PAT-CR rates. Again, coming to the point, how are PAT-CR rates associated with long-term survival? I think we have enough data across meta-analysis, across individual studies to show that achievement of a PAT-CR in a HER2 positive setting is associated with long-term gains in terms of event-free survival. The gains appear to be relatively better for the HR negative population, the hormone receptor negative population. However, even when we consider a hormone receptor population, achievement of PAT-CR improves outcomes. We have a pooled analysis of neoadjuvant trials, some of which actually had patients receiving pertuzumab as well. And even the combined analysis showing that patient who did achieve a PAT-CR ended up receiving a better long-term outcome than those who had residual disease. And this is irrespective of ER and hormone receptor status. Now, one of the key points that we debate is, what about 3-year outcomes in a patient who achieve PAT-CR? Now, we do know that even those patients who achieve a PAT-CR, some of them have a recurrence. And the question that we ask is, whether these patients receive only trastuzumab with chemotherapy and complete 1 year of trastuzumab, how do they stack up against those patients who receive trastuzumab and pertuzumab, that is dual anti-HER2 therapy along with chemotherapy, and then just receive trastuzumab in the adjuvant setting, versus those patients who receive dual anti-HER2 with chemotherapy, achieve a PAT-CR, and then continue to receive dual anti-HER2 trastuzumab, pertuzumab in the adjuvant setting to complete 1 year. Now, this is very exploratory and perhaps hypothesis generating smaller numbers, but numerically it does appear that those patients who not only receive dual anti-HER2 in the neoadjuvant setting, but also continue to receive dual anti-HER2 in the adjuvant setting, are the ones who have the best EFS rates at 3 years. So again, possibly, an argument in favor of continuing trastuzumab and pertuzumab, even for those patients who achieve a PAT-CR when they receive the combination of trastuzumab, pertuzumab chemotherapy in the neoadjuvant setting. So the overall summary of pooled analysis clearly showing that those patients with HER2 positive breast cancers who receive neoadjuvant chemotherapy, achievement of PAT-CR is associated with improved outcomes irrespective of hormone receptor status. We know that those patients who do achieve a PAT-CR would still have a small but a significant risk of recurrence, and therefore I think while we are focusing on achieving a PAT-CR and escalating treatment for those who do not achieve a PAT-CR, it's still important to continue having some attention on those patients who do achieve a PAT-CR, and in at least some of the initial studies, initial data does seem to suggest that those patients who do achieve a PAT-CR, continuation of dual anti-HER2 therapy, that is trastuzumab, pertuzumab, is probably associated with best outcomes. While as clinicians, we want to have more mature data, and I think more data is on the way, more mature follow-up is awaited. Lastly, what are the NCCN guidelines? Clearly, preferred regimen for HER2 positive cancers include chemotherapy, either anthracycline containing or without anthracycline, along with trastuzumab, and for those patients, and in fact pertuzumab. And if those patients who do achieve a PAT-CR, you have the option of continuing pertuzumab along with trastuzumab, and those patients who do not achieve a PAT-CR, there's the option of escalating to TDM1. And while if a patient for whatever reason is not able to escalate to TDM1, trastuzumab and pertuzumab can still be continued. So with that, thank you very much. Thank you, organizers, for having me here, and back to the organizers. Thank you.
Thank you, Dr. Devbrat. So we move to another session. So this is HER2 negative. So it means TNBC and ERPR positive. So this is sponsored by AstraZeneca. So none other than Dr. Ullas from Rajiv Gandhi. So in the era of precision medicine, so there is something to offer more in this setting in early breast cancer. So Ullas, all yours.
Can you, okay. Am I audible, visible? And am I vaccinated? Okay, fantastic. So doubly vaccinated and Omicron positive. So the third vaccine is not yet due. Okay, so I have been asked to speak about the HER2 negative early breast cancer in the era of precision medicine. And my first thoughts when I initially saw this topic was basically, everybody knows my fascination towards lung cancer. This is atezolizumab in combination with chemotherapy and surgery in stage 2, stage 3 lung cancer. And even with atezolizumab, you have a 3-year survival of 60%. And we are going gaga over there. There are more there are more lung cancer meetings nowadays than what are breast cancer. Now, this is a simple, plain old chemotherapy data in stage 2 breast cancer. So, if you can see over here, you have 5-year survival of 70% in stage 3 breast cancer without immunotherapy. And this is like, I always call the problems in lung cancer begin when the problems in triple negative actually end. It's like a poor man's versus a rich man's problem, So we are the poor people of lung cancer, and all Dr. Minu Walia and, Devrat Arya and Ghansham, everybody, Sudeep are all big time rich people's problem. And that is why they probably shifted my session also 15 minutes late. My subsequent reactions over there was But good, better, or best, never let it rest, because tomorrow your good has to be better and your better is the best. That is what we actually strive for. So what exactly are we talking about when we talk about HER2 negative breast cancer? We know a triple negative breast cancer is very easy, which is basically negative for ER, PR, and HER2 new. 15% of all the cancers, younger women, maybe or some of them are BRCA1 positive. But what about ER, PR 1 to 10%? You know, when various definitions have taken ER, PR more than 10% as HR positive. So this is what I am asking. You know, I am the Gabbar and the Samba is the other one, which is ER 1 to 10. What exactly is their issue? So if you can actually see over here that if you have, this was the Munich Cancer Registry cohort, which basically says that ER 1 to 9% tumor cells actually behave similar to them as a triple negative breast cancer, and probably should be included in a triple negative rather than being in an ER, PR positive. I'm not saying you do not give them hormones, but the PCR rates, the survival is more likely to be like a ER, PR low patient. So what do we know already know about the triple negative breast cancer? Now I have divided my talk into the pre-COVID era, that is the 2020, and the COVID era, that is the 2020, because most of the advances which have happened in the triple negative have actually happened in the COVID era. So what do we know in the pre-COVID era? That it is only chemotherapy which works, and this is what I actually ascribe chemotherapy to triple negative breast cancer is, you know, ekla chalo re. I am in no way, comparing the chemotherapy to what Rabindranath Tagore ji compared, but that's just a thing. You know, it's only chemo, and more chemo, which used to work for us in the pre-COVID era. So, what are the unanswered questions in the COVID era in the management of triple negative breast cancer? And over the next 12 minutes, I will show you the 5 more important questions which I think are the most relevant questions. That is, what is the optimal regimen in the NACT, the PCR and the DFS conundrum, tailoring the optimal management of residual disease, role of PARP inhibitors, and role of immunotherapy in the neoadjuvant setting. So these are the 5 questions which I'm going to try to address in the next 12 minutes. And hopefully I should be able to do some justice to this. So let's start with the first 2 questions. Then I'll take the next 2 questions, and then I'll take the last question. So a lot of times the surgeons ask us, you know, there is no OS advantage if you give the surgery. You know, I mean, most of the times people will be asking in the panel discussion that 2.5 centimeter, will you give chemotherapy or will you not give chemotherapy? And the standard answer over there is, "Arey yaar, pehle patient mere paas aaye to sahi." I should get the patient to answer that. So what is the difference? And this is what I always tell my surgeons is that if you have an adjuvant setting, you have the diagnosis, surgical resection, adjuvant therapy, and you have relapse or cure. But if you have neoadjuvant therapy, then you actually, after surgical relapse resection, you actually learn, you adjust the chemotherapy regimen, and then you treat. It may or may not change the relapse or the cure patterns, but definitely there is an advantage to giving neoadjuvant chemotherapy, something which we were not there before. So let's go back to the much more before the pre-COVID era. There were 2 trials, the NACBP18, this is for the benefit of residents, which compared surgery followed by chemotherapy or chemotherapy followed by surgery. This trial showed that there is no benefit, there is no OS advantage of giving neoadjuvant chemotherapy. The OS was 55% and 55% at a 16 years of median follow-up. I mean, that's fantastic actually. Another trial which said, okay, you give anthracyclines for surgery, you give anthracyclines and taxanes before surgery, or you give anthracycline, surgery, and docetaxel. And this trial also basically showed that there was no difference in the overall survival as far as whether you give neoadjuvant chemotherapy or adjuvant chemotherapy. But what it basically showed, was that if you achieve a pathological complete response, there's a better overall survival. So the blue was basically in the pathological CR, both in NACBP 18 and 27. However, there are always skeptics, and what the skeptics basically showed basically was that if you have, so what they did was we are medical oncologists. We love to dissect the data, and after dissecting the data, we are saying no, it's a subgroup analysis. So then we will not take it. But What is the difference in PCR rate if you have the prognostic implication of it by subtype? So PCR rate, for the benefit of my younger colleagues who are just learning the trade of managing breast cancer, if you have a luminal A or luminal B, it does not make a difference whether you have a PCR rate yes or no, because you already have not yet given the most important hormone therapy till there. But if you have a non-luminal to HER2 or triple negative breast cancer, it makes a hell lot of a difference, because people who achieve PCR rates are the ones who will do much more better. People who do not achieve PCR rate are the ones in yellow. So just remember, in your life, if you achieve PCR, you're going to become like Dr. Ghanshyam Biswas and Dr. Hemant Malhotra. If you do not achieve PCR, then you know whom are you going to behave like. So always try to become like a patient who gets achieve a good PCR. This is again another registry which was there by Kotzar et al., which basically showed that if you have a HER2/neu positive or a HER2/neu negative, triple negative, if you achieve a PCR, it is very, very, very important. So the first story, does the PCR matter? Yes, it matters. It matters in triple negative. It matters in HER2/neu positive. No two thoughts about it. In fact, I would like to remind you a very important quote which I learned from Dr. Sudeep Gupta. He said, it is not the presence of PCR which matters. Actually, it is going to be the absence of PCR. So he said, if you have a pharmaceutical company and your drug does not achieve a PCR, then it is not worth investing in that. So that's a very important point that I learned from Dr. Sudeep. And there's so many points to learn from Dr. Sudeep. You just listen to him and he's an epitome of knowledge. So PCR, does it make a difference? Yes, PCR makes a difference in the triple negative setting. Now, let's go to the second question. That is the role of platinums in the neoadjuvant chemotherapy. This is Valentine's week, and I'm sure the reason why I was slightly angry because 15 minutes my talk got late was because my wife and children are waiting downstairs for a pre-Valentine. And I don't want my Valentine to turn into a Billantine tomorrow. So we were told that diamonds are a girl's best friend. I have been told about this in this Valentine week all throughout. But is platinum a triple negative breast cancer best friend, or maybe even a friend? So this was the evidence so far in the pre-COVID era. The major three trials were conducted. One was the JEPAR trial, one was the CALGB trial. Both of these trials showed an increase in PCR. One showed an increase in EFS. One did not show an increase in EFS, and that is why meta-analysis was done, which basically showed in 2,109 triple negative breast cancer patients, the PCR improved. How much did it improve? 37% versus 52%. From anthracycline to taxanes, how much did it improve? 18% to 22% to 37%. Similar jump was there if you add carboplatin to that. So definitely your PCR increases. However, there was an increased bone marrow toxicity, which we learned to manage. So in a fit patient, probably if you want to have an increase in PCR, definitely do that. However, the story basically is not about the PCR. It's not like if you achieve a PCR, you are never going to have a relapse, or if you don't achieve a PCR, you are 100% going to have a relapse. The EFS in the 748 patients of triple negative breast cancer, this meta-analysis showed, did not reach a statistically significant value. The EFS HR was 0.72 and the OS HR was 0.86. So it didn't, although it did cross the unity, but the EFS was not really increased. Basically, if carboplatin was given. So PCR, yes. EFS, no. This was all that was in the pre-COVID era. Now let us see what happened in the COVID era. So in the COVID era, what did the COVID era reveal in the platinum TNBC conundrum? And this was a brightness trial. For people who are still awake and whose wives are still giving them time to not celebrate Valentine week, brightness trial was presented in ESMO 2021 Congress. Very simple. You have one arm, paclitaxel, second arm, paclitaxel carboplatin, third arm, paclitaxel carboplatin veliparib. So this is a very nice trial which basically served to say there were primary endpoint was the PCR, secondary endpoint was there. So the primary endpoint was basically if pacli carbo veliparib was better than pacli, fair enough. If it is better, then whether pacli carbo veliparib was better than pacli carbo. So this was the primary and primary endpoint of the trial. What this trial basically showed was that the pacli carbo veliparib, the triplet regimen, was better than the singlet. but the triplet regimen was not better than the doublet. So very, very important. That is one thing which is very, very important. So there is no role of giving PARP inhibitor in a neoadjuvant setting, even if you are BRCA1 mutant. This was the EFS now. EFS also, the two curves over here are basically Hemant Malhotra and Ghanshyam Biswas, both at the top. The blue curve there is Ullas Batra coming down. So whether you have triplet or you have doublet, absolutely okay. If your doublet is doing as good as your triplet, why do you want a triplet? So a two-drug regimen, Paclitaxel's EFS was similar to the triplet. However, the only Paclitaxel arm was going lesser. Mind you, again, there was no OS advantage over here. Now, whether this result was basically correlating with the other one, whether this result was an outlier. So if you look at this left side graph over here, this result which was achieved in the brightness trial was consistent with the control arm of the Keynote 522, a PCR of 51% and the 3-year EFS of 76.8%. So by and large, if you get a platinum, you're going to achieve a PCR of approximately 51% and a 3-year EFS of 76.8%. That is what we are getting from brightness. Important questions. Implications of brightness if you have a germline BRCA mutant, or if you do not have. That's a standard question I ask my residents. Will you send for BRCA? Yes, no. Will it change? So if you are giving Paclitaxel, look at this graph. There was no significant difference benefit from adding carboplatin, whether you are BRCA wild, whether you are BRCA mutant. Carboplatin was increasing the PCR, period. The same result was achieved in the JPAR trial. Now, if you are germline BRCA mutant, should we add Velaparib to the NACT? Because Olympiad has shown the benefit. Unfortunately, again, this trial did not show that there was a benefit of adding triplet. So this trial, basically, what this trial is showing is that there's a higher benefit of carbopacli versus pacli alone, but there is no added benefit of Velaparib even in the germline BRCA mutants. That is the bottom line. This is the most important summary of this trial. So the first two questions: what is the optimal chemo regimen in ACT? Whether it is only ACT, yes, definitely. Platinums definitely do increase the PCR and increase the toxicity. I have started discussing platinums with my patients, irrespective of their germline BRCA1, BRCA2 status. There is another reason for that, which we will know in the Olympia trial. In a fit patient, the PCR and the DFS conundrum, definitely there is a PFS positive correlation. Again, what Dr. Sudeep Gupta said, if you do not achieve a PCR, please do not invest in that particular drug again. Now let's look at the optimal management of the residual disease. This was the pre-COVID era. You give 4-AC/4 to your Paclitaxel, and then you have a standard and you have a residual disease. If you give the capecitabine, there is an OS advantage. Again, look at capecitabine and control arm over here. Even look at the OS advantage. There was a 5.4% OS advantage, which is fantastic, which is what exactly you get in the trastuzumab arm. Again, this is what it basically shows over here. There's an absolute 5-year OS benefit of 8.5%. The benefit of trastuzumab versus taxanes against anthracyclines, I think, was 5%. Trastuzumab versus only ACD was 5%. And CREATE trial, capecitabine is the only one which has given a 5-year OS benefit, an absolute benefit, which is fantastic. So we definitely have a winner in capecitabine. If you go ahead and if you give neoadjuvant chemotherapy, you do not have a PCR. Definitely go ahead and give them Createx. That brings me to the Olympia trial. What happens if your patient is BRCA1 mutant also? So this is the trial, fantastic trial. This trial basically took HER2 negative people who had achieved PCR, or people who are in the adjuvant group. If they were neoadjuvant, they should not have had a PCR. If they were in the adjuvant, TNBC more than 2 centimeter or any lymph node positive. If you're an HR positive, you do it in the more than 4 lymph nodes positive. Very, very important. Olaparib was given for approximately an year, and concurrent adjuvant therapy was allowed. And very important is, you give tamoxifen, you give bisphosphonates, but no other chemotherapy was allowed. And this was what it showed, an invasive DFS of 85.9 versus 7.81%. That means HR ratio of 0.58. This is similarly of HR ratio which we get in the lung cancer pembrolizumab arm, and that is costly. And this drug is given only for 1 year, so that was definitely there. Everything was in favor of olaparib. There was not even one subset which did not derive benefit. Yes, people who had received prior platinum did not derive as much benefit from olaparib, but not to say that they did not derive any benefit. Again, the confidence level was basically above the utility. This was the only thing which did not derive that much of benefit. Again, 87.5% patient who had a distant disease-free survival, absolutely fantastic. OS basically, again, you had a 3% difference. The trend was towards a survival with giving olaparib. Now, if the drug is so good, there has to be toxicities. And I remember when we were initially giving olaparib, there were always concerns about the MDS and the AML. But this trial basically showed that there was not much difference in the MDS or AML between the two arms, between the arm that got olaparib versus the arm that did not get olaparib actually. Okay, so there was no clinically meaningful change in fatigue severity. The fatigue was absolutely okay, and there was the vomiting, nausea was by and large equally was very well. The drug was very well tolerable. There were no major side effects actually over there. So with capecitabine, I wrote that there was one winner. But again, with olaparib, I'm telling you, we have a joint winner right now. We have capecitabine also as a winner. But if you have a germline BRCA positive, you definitely have that data for olaparib, which is very, very good. So the first two questions I answered. The third question is, if you have a residual disease, either capecitabine or olaparib, role of PARP inhibitors, definitely not an NSCT, but definitive role as far as the Olympia trial criteria is concerned. That brings me to the last some 10 slides. Role of immunotherapy. Those are my best slides actually over here. And the immunotherapy is what is I call as a bahubali of lung cancer or any cancers right now, because they are going to be the saviors. Let's look at the immunotherapy in the pre-COVID era. You basically have 4 trials till now. Keynote 522. This was again the pre-COVID era. And a very interesting story about 522 is that the data was presented actually in 2020 initially, where there was an increased PSCR, but the FDA said that they wanted to have a look at the EFS. Impassion trial showed there is an increase in PCR. Neotrip showed the data is immature, and Japan Nova also showed that the PCR is increased. So remember, I started with showing you the PCR data. If you add immunotherapy, you definitely have an increase in PCR, definitely. Now, do you have an increase in the EFS also? That is what all of us want. Again, very, very important is please have a look at this data. The platinum story, which I showed you initially, in this subgroup, the carbopactly arm was given initially, and carbopactly actually was the standard of care. So I think it's time for all of us to move to, okay, it's a suggestion. If you have a new patient who cannot probably afford olaparib later, it may not be a bad idea to start with a fit patient, a platinum and an anthracycline taxane-based combination. In this, the pembrolizumab was given for adjuvant setting also. This was the first analysis at 2020, I guess. There was an increase in PCR 64.8 versus 51.2. So that is 51.2 was exactly what we saw in the brightness trial. And there was a trend towards survival at the interim analysis too. But FDA said we want more data, and the more data basically came in the COVID era. This was the ESMO virtual plenary session in May, which basically said a 7.7% absolute difference in the mortality in the EFS, which was very, very good. And this is even more important. This is a slide which I actually want to show you. If you achieve a PCR, maybe you can discontinue the pembrolizumab, something over here. But if you do not achieve a PCR, please continue with pembrolizumab, because if you do not achieve a PCR, you have a 67.4% survival vis-a-vis 56.8 if you discontinue that. That's something which is very, very important. The overall survival is immature, but there's a trend towards overall improvement. Now, I'm a PDL1 person. I have put my, I have always claimed that PDL1 in lung cancer and head and neck cancer is very, very important. But is PDL1 a predictive marker for immunotherapy in breast cancer? Unfortunately, the answer is no, or fortunately, the answer is no. Both people with PDL1 status positive and negative did respond to immunotherapy as a neoadjuvant setting. Now, important question. Just last 3 slides, listen to me. There are a lot of people who come and tell us, that, okay, fine, it's a very small disease, node negative disease, node positive disease. Should we not, it's not a very high volume of disease. Should we not just skip immunotherapy? No. If you have a keynote 522, the PCR which was achieved was basically 64.9 versus 64.8. So your chances of getting a PCR actually increase. The delta is obviously smaller because a small node will also get benefit from chemotherapy. So if you have a young patient who is willing to spend that much amount, probably Dr. Ghanshyam Biswas and Hemant Malhotra's patient, not my patient, you can actually go ahead. The similar results were basically there in Impassion 031. Again, the advantage in the PCR was 13%. Impassion 031 also showed a 16% advantage. The consistency, Rahul Dravid is always there. And you have a 3-year EFS of 84.5 versus 76.8. The Japan Nuevo trial also showed the same data. So by and large, looks like immunotherapy is going to make its foray in the immunotherapy ward in neoadjuvant setting. So my last answer, what is the role of immunotherapy in the neoadjuvant setting? Impressive results. If we have a patient who can afford, who is willing to understand, it would be worth considering giving immunotherapy in the triple negative setting. To conclude, hope was always there with the lung and breast cancer. I was the one who extrapolated hope to lung cancer, but hope is the original one for triple negative or breast cancer. And this is my last and favorite slide. It's actually so exciting to think that some of the best moments of our lives are yet to happen. The best moment of life probably will be when my children start going back to school, when probably we meet each other for a physical meeting over there, and probably when we are going to get cure in breast cancer and other malignancies as well. With this, thank you. And Dr. Hemant, I hope I have done justice to the talk. It is not only the lung cancer that I treat. Thank you.
So thank you very much, Dr. Ullas. I think you are an expert both inside the chest as well as outside the chest. So was this the last talk in this session?
Yes, sir. Yes.
So great. So if I were to very quickly sum up before I hand over to Dr. Ghanshyam Biswas for his impression of this session, just 1 minute. We had, breast cancer somehow has been lagging in the approvals and the usage of immunotherapy. But it seems now that the triple negative disease is going to make up for that lag. And we had 3 presentations to start this session with on the use of immunotherapy in the neoadjuvant setting. We had 2 excellent talks on HER2 positive disease, both in the, adjuvant setting when you have residual disease and in the neoadjuvant setting where unequivocally we are aware now that dual HER2 blockage is better than single HER2 blockage. And then we had this beautiful roundup by Dr. Ullas Batra in which he, gave us a very nice snapshot about targeted therapy in breast cancer, starting from triple negative breast cancers and, finishing with, again, a very nice summary of immunotherapy in breast cancer. I'm very impressed with the event manager also, particularly with Tarun. Tarun could, dare to cut short the organizing secretary of the meeting also when she was exceeding her time. So that is particularly impressive to me. So that's the kind of organizing the event organizers we need to keep everybody on time. So those are my impressions and my pleasure and honor to be part of this CME and this webinar. I enjoyed myself. Significant knowledge gain happens thanks to all the speakers. And now I hand over back to Dr. Ghanshyam for his quick snapshot of his takes on this session. Over to you, Dr. Ghanshyam.
Thank you, sir. Thank you so much. So we do understand that lots of things are happening pre-COVID, post-COVID, in triple negative, in HER2 space. Even for a hormone positive where there's significant disease volume. So probably, so we are looking at trials like Olympia. So I think there was there are too many things happening. So at this moment, so we need to have a sequencing. We need to have so many biomarkers. So lots of learning on a Sunday afternoon. Thank you all. So thank you, organizers.
Thank you, Dr. Gansham, and thank you, Dr. Hemant sir, for chairing beautiful sessions on triple negative breast cancer. And thank you, Dr. Ulas Patra, for entertaining, intellectually telling us everything about the triple negative breast cancers, and also making your Valentine into Valentine. We are very, very sorry for the delay. And without further delay, I would like to invite the next set of chairpersons, again, mentors of my oncology from the west side. I have the honor of inviting Dr. Bharat Bhosle and Dr. Ashe Kape sir, both directors, Sunrise Oncology Center, Mumbai, Thane, Goa. And to add to their accolades, I believe they have just won the Indian Achievers Award, which is one of the unique award that has been there since 2000 for in recognition of their outstanding professional achievements and contribution in nation building. So over to Dr. Bharat Bhosle sir and Dr. Ashe Kape sir for the next session. Dr. Bharat sir.
Yeah, thank you, Vikas, for the introduction. And I would like to congratulate you for the wonderful organization for this meeting. Without wasting time, I would like to start the next session. I request Dr. B.K. Smurthy. She doesn't require any introduction. She is the one of the senior most medical oncologists of India. She works at Lilavati Hospital and Bombay Hospital. Over to you, madam.
Well, I'd like to thank the organizers for having invited me to this excellent meeting. Well, I'm venturing into the realm actually of, the radiotherapists and the surgeons as far as my topic is concerned. But in the course of the discussion on the presentation, I'll let you know how important it is for the medical oncologists to know this, because we are the ones who are going to deal with this situation, and we are the ones who would like to know where it is applicable to be aggressive in the oligometastatic disease. So coming to this topic of oligometastatic disease, the definitions and practice patterns. So, it's been like a dichomatous cancer where you consider only localized disease and systemic disease. But in the year of 1995, Hellman, with his spectrum hypothesis, introduced the concept of a limited metastatic disease, where in the metastasis is slowly progressive and if ablated could lead to long-term survival. And as you can see, following this, you can see that there has been an active interest in this subset of patients, be it any type of histology. And this led to the phase 1 and 2 studies, which were activated in the year of 2014. And then you had a randomized phase 2 study data from 2017 onwards. So the interest has grown, and let us see what it has led to. Now, the first question that comes is this a biologically distinct disease? So if you look at the microRNA expression, which was shown by Luzier et al. In the year of 2011, the microRNA expression does differ between the oligometastatic and the polymetastatic disease. And if you look at the biological features, then you see that this is more favorable in the oligometastatic disease because there is less of aneuploidy, less of heterogeneity, and there is more of immune infiltration. On the other hand, if you look at the polymetastatic disease, it is aneuploidy and there is a lot of heterogeneity and there is activation of aggressive pathways and the epithelial mesenchymal transition, which leads to immunosuppression. So if it is a disease which is biologically distinct, then how do you define it? So you can see that although there is a biological rationale for oligometastatic disease, there is a complete absence of molecular markers. So as of now, it is actually defined by imaging guidelines. The first guidelines, of course, that I would allude to are those by the EORTC on the right-hand side, where, of course, you have conventional imaging, and then, of course, the additional imaging by FDG PET, and, of course, using of MRI in certain circumstances, like if there is liver involvement, which is, equivocal, then you could use MRI for the liver, and then same thing with the brain. The European, the ESMO and the NCCN guidelines are almost in a similar direction. The only difference being that in the NCCN guidelines, it actually requires that if there is an equivocal lesion, then one should resort to a biopsy. So that's the only difference, but otherwise all are in the same direction. So with this, led to the characterization and classification of oligometastatic disease with a combined effort from the EORTC and ESTRO. And this was recently published in the Lancet Oncology in the year 2020. And you can see that the whole panel of experts asked 5 questions as shown on the left-hand side. Of course, due to paucity of time, I can't go into the details, but what it led to was that there are 9 states of oligometastatic disease. And to put it very briefly, this is a very important chart. You can see that on the left-hand side, you have the de novo oligometastatic disease, and there you have 3 situations where it could be synchronous at diagnosis and metachronous. That means you treat and then there may be an oligorecurrence after a disease-free interval, or on treatment there could be a metachronous oligoprogression. Then you have a situation where at presentation there was oligometastatic disease, then there was a disease-free interval, but again at relapse there is a oligometastatic disease, and this may be in the form of oligoprogression while on treatment, or oligopersistence. That means there was a complete response on treatment, but there was a progression in only a limited area. And last but not the least is the induced oligometastatic disease. That means you begin with a patient who has a polymetastatic disease, but the response to treatment is so good, and that is what you see in breast cancer nowadays with all the new therapies, and that leads to an induced oligometastatic condition where only you have one particular site of disease. And then on treatment, the patient may have an oligoprogression after a state, and then after that there is an induced oligorecurrence. So these are the 9 states, and this had to be validated whether this has clinical relevance in terms of survival. So you can see that there is this is the group. He was actually the first author in the previous study, and he looked at his own cohort of 389 patients of breast cancer. And what he saw was that these patients who had treatment for maximum 5 metastases, the de novo oligometastatic disease and the repeat oligometastatic disease did much better than the induced oligometastatic disease. Now, there are the definitions of oligometastatic breast cancer by the ESO and ESMO, as well as the ESTRO and ASTRO. And again, they are quite similar. They actually take into consideration the definitions by combining the anatomical description, that is up to 5 metastases, with the possibility and choice of implementing a therapeutic strategy with a curative intent. And in my association with the ABC guidelines, the actual definition is very similar. Now, what is the incidence and survival? You can see that it's very variable depending on which cohort of patients you're looking at. It is 50% in recently enrolled MBC trials, whereas it would be to the tune of 17% if you were to follow up patients with early breast cancer who are treated. And here it is 1 to 5 metastases. And what is the median survival? It of course depends upon which subtype of breast cancer you're looking at. But if you were to look at the older data, which actually correlated survival with the number of metastases, you can see that up to 5 metastases has the best median survival, and the least survival is with polymetastatic disease. So again, in here too, you have 3 different scenarios which are important in the clinical context. You have the de novo OMBC, then you have the oligorecurrent breast cancer and the oligoprogressive breast cancer. And what is important is when you consider metastatic disease, you have the low risk, which is the topic of discussion in my presentation today, and the high risk where there are polymetastases. And you can see that in the low risk population, the local ablative therapy has a major impact also, whereas in the high risk, it's the systemic therapy. And here, of course, I would allude to what are the local treatments that are to be looked at in this particular setting. You have radiotherapy, that is now mainly the SBRT and SABR. Then, of course, you have surgery. Now, this slide I have just used to summarize what was actually discussed in another session at the just concluded SABCS. For paucity of time, I can't go into the data, but this is just a summary that where could you offer surgery in this setting. So there are specific indications for loco-regional therapy. As you know, there were 3 important studies. One of the important studies being from Tata Memorial Hospital, where they showed that there was no survival benefit for loco-regional therapy. But that really does not rule out loco-regional therapy at some points of time. So this could be considered when you have a good control of metastatic disease in younger patients, those who are hormone receptor positive and those who have bone-only disease. And I know that there are instances where we have used this also in patients who are HER2 positive, but have a completely controlled disease for a long duration of time, but with a local progression. It is very interesting to know that inflammatory breast cancer also has a area where you could consider local therapy. And this is very important data from the MD Anderson Cancer Center, where the MRM of the primary tumor has actually offered better overall survival. And also in the retrospective data, as well as the prospective randomized trial being not possible in this situation. So at least there they do offer MRM to select de novo stage 4 inflammatory breast cancer, and the data was shown where it did improve overall survival and also the quality of life. Then, of course, the situation where you have limited metastatic disease, contralateral axillary metastasis, this also should be aggressively dealt with because it has improved the survival with surgical and radiotherapy as the options that are available. And of course, despite the 3 studies, select patients in the metastatic setting for improving the quality of life or for palliative purposes could be offered MRM so long as there is no residual disease or the margins are clear. Now, coming to radiotherapy, there's really no phase 1, level 1 evidence, but you have several phase 2 randomized studies in different histologies. Like colorectal, non-small cell lung cancer, and the last but the most important being the SABR COMET study, which was recently presented at the ASCO 2020. And you can see that actually this slide doesn't show it, but there was a progression-free survival benefit in all these subsets. But the overall survival benefit was seen in 3 of the studies, and especially in the SABR COMET study. So coming to this study where different histologies were offered local therapy in the form of radiation, that is SBRT, and breast cancer, of course, constituted a part of it, a small part of this. And you can see that whereas the overall survival or the progression-free survival was concerned, there was a significant benefit for these patients. Then this is again the other study which has been published recently, And you can see that this is the benefit according to the molecular subtypes. And you can see the median overall survival is 7.1 years, retrospective 79 patient data, and SBRT being offered to less than 5 lesions with a median follow-up of 50 months. And one sees that actually the TNBC cohort will not benefit, but definitely the hormone receptor positive and HER2 positive patients definitely benefit from this intervention. Now, there are several ongoing studies of consolidative radiotherapy to block oligoprogression, like the CURB study, where you've got 80 breast cancer patients and 80 patients with lung cancer. And then you have PFS as the endpoint. Then you have other studies as well as mentioned over here. And there are now actually having phase 3 studies, and we look forward to the results from these studies. Now, coming to the important aspect which was brought out here is the changing multidisciplinary treatment here. So this is a real challenge for accumulating or conducting clinical trials in this setting, because you see all these various treatments that we use are undergoing paradigm changes over the last few decades. So there is a very important collection of real world evidence, and that is the Astro EORTC study. The goal, it's called the goal of E2 Radiate, where you do collect the real world data where oligometastatic disease is treated with radiotherapy, and you have all the clinical data as well as the outcome data in these patients. And actually there are 3 cohorts, and the one of the cohorts is called as the oligocare. It's an observational cohort, and it is important to understand that the radiation protocols are actually standardized all over these centers, and the outcomes are very well recorded. And the patients are objectives are identifying the patients who have received this treatment, and the diagnostic methods use the treatment characteristics, and evaluating the patterns of care and the toxicities. The primary diseases included in this prospective collection of data is the real world evidence is in the lung, breast, prostate, and colorectal cancer. There's no upper limit of number of metastases, but all should have received treatment for the metastasis with a radical intent, and at least one with radiotherapy. There are 37 sites in 10 countries, and these are the initial results of 395 patients irradiated. And you can see that the fields used were between 3 to 5. The dose per fraction was around 10 gyri, and you can see in this cohort, the breast cancer patients were less in number, but I think as the data accrues, you will get more patients with breast cancer. So you have real world evidence on SBRT from Belgium, England, and the oligocare center. And you can see at the bottom that the overall survival are quite gratifying, with 1 year 85% and 2 years 70%. And in the UK study, which is important because here you also look at the local recurrence rates, the survival and the toxicity, and you can see that very gratifying 1 year and 2 year overall survivals. So if you look at the Belgium study, here also this is accumulation of the real world data. So far they have collected data on 2,790 patients, most frequent primary tumors being colorectal and prostate, but breast cancer constituting about 9%. The average number of lesions per patient was 1.22, and you can see the lesion size. And what was seen here is it's very surprising that lung cancer did not do so well. The best results were with prostate cancer, and of course the intermediate results were with breast cancer and colon cancer. Then this is the real world data from the UK study, and it also is similar to that seen with the previous study, and the overall survival is very gratifying. And here also the better outcome was seen in all other cancers, but not so much in the lung cancer cohort. The adverse events were quite acceptable. So coming to the conclusion of my talk, metastatic directed therapy in breast cancer, you have retrospective data to actually support this. There is a clinical benefit for metastatic directed therapy in other histologies. The SBRT is ablative with anatomic precision. And breast cancer specific unanswered questions are how best to select patients for local therapy and how to monitor patients after treatment. Well, I showed you the sum of the data, and I think especially those patients who are endocrine responsive or HER2 positive and who have a long duration of control, I think these are the patients where you really need to consider it. In the TNBC cohort, of course, this is all data from the previous studies where you had just chemotherapy as an option for TNBC. But now with the advent of new systemic therapies, you might come across certain patients with triple negative breast cancer also who could be offered this strategy. So what is the last slide show is the Astro and Astro consensus. And what is important is, it is just alluding to whatever I have mentioned so far. But the last line is very important, that when you talk of oligometastatic disease, it's not only defined by the number of metastases, but it should have a controlled primary tumor and where all metastatic sites could be safely treated, whether it be by radiotherapy, surgery, a combination of this, or even radiofrequency ablation. So with this, I think it is important, I think the message that as a medical oncologist treating metastatic breast cancer, you need to know that there are certain patients with metastatic breast cancer who would derive benefit from local therapies, and it's very important to keep this in mind. So although the methodologies are, non-medical, but I think since we are treating the patients, we should know when we should allow others to intervene in the natural course of the disease. Thank you.
Dr. Vikas, you're there? Dr. Vikas, sir? Hello, Dr. Vikas, you're there?
Yes, sorry.
Yeah, so if you can just conclude.
Thank you, Dr. Smriti ma'am, for a wonderful enlightening session. We were mesmerized totally by it, and thank you for enlightening us and giving us insights into the same. And I suppose Dr. Bharat had introduced you brilliantly, and your name doesn't need introduction to the medical oncology fraternity. Now, moving over to the next session, we have the pleasure of inviting none other than Dr. Stephen Gluck, who the Vice Medical Affairs Oncology, Regeneron Pharmaceuticals, Celgene Corporation Summit, New Jersey, USA, for his topic on the immunotherapy use in breast cancer, key takeaways from the SABCS 2021. Dr. Stephen Gluck, the talk we have as a pre-recording for him.
Hello, from Miami Beach to India. It's a privilege and great pleasure to be able to present the newest data on breast cancer from San Antonio in December 21. I will focus on the ICI, immune checkpoint inhibitors, and give you a quick introduction so it's not too dry just presenting you data. Those who don't know me, my name is Stefan Gluck. I'm a medical oncologist, practiced many years at the University of Miami, visited India many times, and unfortunately, as said it is, last time in India, I was in February 2020, so almost 2 years ago. And of course, I miss my friends, many friends, the hospitality, the warm welcome, and the food of India. Hopefully, I can join you soon. Immune checkpoint inhibitors change the paradigm of cancer treatments, and I will be very brief here. we have been targeting the cancer cells or tumor cells for decades and tried to eradicate the tumor with surgery, radiation, chemotherapies, biologic therapies, and so on and so forth, molecular antibodies, what you have, and quite successfully if you compare survival rates from now 10, 30, 50 years ago. But the new paradigm shift is that now with the immune checkpoint inhibitors, we are targeting lymphocytes, the effector cells at the end of the day in the immune cycle are harnessing and kill the cancer cells. So we are helping the body to fight cancer. Very famous picture that you have seen many times. I will also not spend too much time on it, but it tells you two things that are important. First is the tumor in gray on the lower part in the picture shows fast growth. And as these tumor cells grow, and some of them release neoantigens. These neoantigens, number one, are being identified by antigen-presenting cells, especially dendritic cells, showing the new, not recognized antigen to lymphocytes in the lymph nodes. These non-active lymphocytes are being activated, and one of the checkpoint inhibitors is the CTLA-4, which needs to be active. These cells go to the bloodstream, and at the end, they find, number 5 and number 6 on the slide, recognize the cancer cells and can target them and lead to cell death, number 7. These are the effector T cells or cytotoxic T cells, CTLs, and these are being inhibited by another checkpoint, by the PD-1 and PD-L1 axis. So the PD-L1 is on the effector cell, and the PD-L, the ligand, L1, is being released by the cancer cell, so the T cell will be inactive. Now, we have seen major successes in patients who have cancers like melanoma, like MSI-high cancers, like bladder, like lung cancer on the right side. And what is it showing here is the number of neoantigens and mutations that are discovered. There are a lot of them. In breast cancer, the number of mutations, hence neoantigens, are much, much lower. And therefore, breast cancer has not been on the first day and not the first disease that we are targeting with immune checkpoint inhibitors. So what happens now, we are helping the immune checkpoint inhibitors in breast cancer, particularly with the combination with chemotherapy, especially in triple-negative breast cancer. These have slightly more mutations than the other subsets of cancers, and we expect that neoantigens are being higher in this disease. And there's a number of reasons why chemotherapy should be used. One of them is, again, to pre-select these cells that are sensitive. They can be killed by chemo and release more neoantigens. But also, it can enhance, if dosed right, for example, low dose and weekly, it can enhance the immune response, which we know in triple-negative breast cancer is so important. Now, some of the compounds need steroids as pre-medication, and therefore the group around Roche Genentech combined their compound atezolizumab with nab-paclitaxel without steroid use, and of course, their compound is known as atezolizumab. So this study, we all know, was a very positive one. This was IMPassion 130, and I will spend only half a minute on it, showing to you clearly that it actually can work. The atezo arm plus nab-paclitaxel was better than the placebo plus nab-paclitaxel arm, as you've seen on the intent to treat and progression-free survival with patients who have high PD-L1 expression, basically positive, 1% or more. This also translates into survival benefit, which I will not show. Well, it's here. Sorry, I'm showing. But at the same time, a study IMPassion 131 was designed, and instead of nab-paclitaxel, paclitaxel was used with steroid premedication, and this study actually turned out to be negative. Therefore, Roche Genentech withdrew its indication for atezolizumab. It was approved and still actually is approved by the FDA, but it is not available via the company. So San Antonio brings us some very new, and I will focus only on two keynote studies, which some of them you heard before, some of them are updated, and they are both positive, as you of course know. So the first one is the Keynote 552 neoadjuvant study, which randomized patients who are consented to the study participation with newly diagnosed triple-negative breast cancer, bigger tumors with lymph node positivity, ECOG status, PS performance status 0 or 1, and they randomized 1,174 patients to receive either chemotherapy alone with placebo or chemotherapy with pembrolizumab. The chemotherapy could be either carboplatinum or paclitaxel for 4 cycles, and doxorubicin or epirubicin and cyclophosphamide. Now, there's a number of exploratory analyses planned, and at the time of surgery, the patient were still enrolled in the study, continued on pembrolizumab alone without chemo or on placebo without chemotherapy. Now, there were a number of analyses planned, and the primary analysis already shows that the HR, the number of events, which is the primary endpoint, shows a hazard ratio of 0.63. So the risk reduction of events on the pembrolizumab arm versus placebo arm is reduced by 37%, more than 1/3. And the analyses that followed a little bit later all show about the same thing. Event-free survival, you of course know, is not only progression-free survival, but also includes progression during chemotherapy, so prior to surgery. Now, further subsets all show benefit, whether it's a nodal status, positive or negative, whether stage 2 or 3, whether it's a menopausal status, whether it's HER2 status, low, of course, because FISH positive and 3+ was excluded, as I mentioned before, or the LDH. And as you see on the right side, the hazard ratios are all about the same, give and take, 1/3 risk reduction. Adverse event, nothing new, very typical for ICI, which means immune checkpoint inhibitors, and they include a very few grade 5, so the death rates, as you see, 1/3 of a percentage point only, or half, so it is relatively safe. Discontinuation happens about 27%, so it is actually not quite without. And you, those of you who use the immune checkpoint inhibitors, they know some of the side effects are immune-related, typical to, similar to autoimmune disease. So the investigators conclude that this therapy statistically and significantly meaningfully improves event-free survival in women with triple-negative breast cancer. Now, in true numbers, which I didn't mention yet, the 36 months event-free survival, so 3 years, is 8% better. As I said, hazard ratio 6.3 when you add pembrolizumab with 2 chemotherapy from 76.8 to 84.5%. Consistent with the other analyses, and it's consistent across all subgroups. Safety is known and not surprising. And so this one should be regarded as standard of care very soon, if not already now. Now, the other study, which is in a similar setting as the Impassion 130 and 131, were first-line treatment in metastatic triple-negative breast cancer, shows similar data. The study was conducted in a randomized fashion of 847 patients. Randomization was 2:1, either chemotherapy alone with placebo or chemotherapy, the same chemotherapy, with pembrolizumab. And the investigators, again, were permitted to use nab-paclitaxel or gemcitabine and carboplatin, typical what one would use in a metastatic setting in triple-negative breast cancer. Obviously, primary endpoints, co-primary endpoints, PFS and OS. And they looked into the positivity of the PD-1, PD-L1 marker, which they call CPS, and 1 and bigger, over 10, and IIT analysis. And this is the result here. The IITs shows some, but slight differences. Those that are only 1+ and more, better. But if patients have a CPS of PD-L1 of 10 or above, the difference is big, and this is survival. This is not only progression-free survival. It's 16 versus 23 months. That's huge for triple-negative breast cancer. And at 18 months, which is 1.5 years, we have about 14% more patients alive if they had pembrolizumab and PD-L1 CPS 10% or more in the biopsy. Now, additional subgroups show you about the same, only if the CPS is over 10, shows really clinically meaningful differences. And it's similarly good in CPS 10 to 19 and 20 or more, as you see on the two lower panels. Adverse event, very similar what we see before. Again, treatment in any grade is 96. Everybody has some side effects, but both in pembro and placebo arm, as you see, 96, 95%. So it's attributed mainly to the chemotherapy portion. Even grade 3 to 5 is not much different. Serious, there seemed to be a 5% difference, and there is some death rates on the pembro arm, whereas on the placebo arm, there is 0. Discontinuation, 18% on the pembro arm, 11% on the placebo arm, of course, both arms on chemotherapy. And the immune-mediated side effects are, of course, mostly, if not all, on the pembrolizumab side, 26.5% versus only 6.3% on the placebo side. Other events, if you want to see them on the right side, these are the individual ones, not a big deal in the gray upper area, and obviously the immune-related adverse events in the lower right part of the slide, you see there are some differences, especially hypothyroidism. So the keynote 355 investigators conclude, and rightly so, that the CPS 10% above is a cutoff for patients with metastatic triple-negative breast cancer. They will have benefit from the treatment using chemotherapy plus pembrolizumab. Both statistically significant, improved is progression-free and overall survival, and I believe it's also clinically meaningful. And the study was positive because the dual OS and PFS endpoints were met. The safety, no surprises, obviously, especially autoimmune and the immune-related adverse events are mainly in the investigator or experimental arm, meaning pembrolizumab, whereas in the placebo, only chemotherapy side effects are observed. So the conclusion is clearly that pembrolizumab and chemotherapy should be considered as new standard. So we are almost at the end of the presentation, so let me summarize what we have learned over the last 3 years. As we heard, one of the investigators using atezolizumab alone initially, and later with nab-paclitaxel in phase 1 and 2 studies, it was very promising. But the phase 3 study, in spite of being positive, showed not a positive result when combined with paclitaxel alone, and not nab-paclitaxel. And now, as we see and as we know, way years later after lung cancer and melanoma, and other diagnoses, we do have positive data in triple-negative breast cancer. And although both compounds, atezolizumab and pembro, showed some promising data in first-line metastatic breast cancer, only the latter, pembrolizumab, should be used because that's where the data show. Again, agreeing with the investigators, CPS 10% or more is the requisite. So below, it would not be deemed and regarded as effective. In a neoadjuvant setting, which is slightly different, only keynote data show positive data, as we have seen in the study just a few minutes back. There is another study quite interesting, the PANUEVO, using durvalumab. And durvalumab shows only in a subset of a subset. It's a small study, only 200 some patients enrolled, and only in a subset of patients that received durvalumab in a window of opportunity, so prior to chemotherapy, shows some positive data. So overall, the study did not show durvalumab as a feasible and effective treatment. We do have now keynote data for pembrolizumab. One thing is clear in breast cancer, and it's not necessarily in lung cancer, in melanoma. We still need chemotherapy as a combination platform. So the ICIs alone will not give us enough. So we are eagerly awaiting the combination with our immune checkpoint inhibitors, other immune oncology compounds. And one is coming very soon, the LAG-3 combination with PD-1 inhibition. And I stop here and thank you very much for the attention.
Thank you, Dr. Stephen Gluck, for an enlightening presentation, and thank you.
So we lost your voice. Now we have a quiz. Dr. Vikas, so we lost your voice.
Weren't approved in the keynote 522, which was the most discussed trial today. The carboplatin AUC 1.5 every weekly, carboplatin AUC 5 every 3 weekly, paclitaxel 80 milligram per meter square every weekly, or paclitaxel 175 milligram per meter square every 3 weekly. Next slide, please. Which of the following endpoints weren't used as the primary sensitive analysis for the keynote 522 trial? The second primary cancer, which is non-breast cancer, the positive margins at the last surgery, or death from any cause. In the pooled analysis of the Mona Lisa 237 trials, which subset didn't have OS benefit with the addition of ribociclib? Luminal A, luminal B, basal-like, HER2/neu enriched type. Next, please. The dose of the metformin used in the MA32 trial was 850 milligram BD, 500 milligram BD, 1 gram BD, 750 milligram BD. Next, please. The fixed dose subcutaneous trastuzumab and pertuzumab in Frederica trial is whether it's trastuzumab 840 milligram, pertuzumab 420 milligram, fixed dose combination. It's 8 milligram per kg trastuzumab, 6 milligram per kg pertuzumab, 1200 milligram trastuzumab, pertuzumab 600 milligram of trastuzumab and pertuzumab subcutaneous combination. Next, please. Which of the following drugs have the maximum overall response rate and progression-free survival in brain metastasis in HER2 metastatic breast cancers? So the first is the drug and second is the trial. We have to find out which is the maximum overall response rate and progression-free survival. So is it the TDM1 in the Camellia trial, pertuzumab plus high-dose trastuzumab in Patricia trial, the trastuzumab deruxtecan in the Destiny Breast 1 trial, tucatinib trastuzumab capecitabine in the HER2 client trial. Next, please. The first oral selective estrogen to demonstrate significant clinically meaningful improvement in the PFS standard of endocrine therapy as second or third line treatment for the ER positive HER2 negative metastatic breast cancer following prior treatment with CDK4/6 inhibitor. Is it amnestin? Is it eloxatrient, exemestane, or datopotamab? That's the end of the quiz of day 2. We will shortly announce the winners for the same. And I really thank whole of the faculty, whole of the sponsors wholeheartedly, every moderator, discussant, faculty, panelist for making this 2 day sessions a wonderful and enlightening and academically enriching experience. I thank Horizon team wholeheartedly for beautifully organizing this virtual meeting across multiple halls where we had well-conducted surgical, pathology, radiation, radiology sessions in 2 days span, and it was a wonderful meeting at the end of the day. At the end, I also want to thank Dr. Minu Walia for helping me and guiding me throughout this meeting. And I thank every delegate for actively participating in this meeting. Thank you. Have a nice day and have a safe Sunday. Thank you,
So
Team
thank you
Horizon.
so much, Dr. Vikas and Dr. Vidu Walia ma'am, for this exciting 2 days event. And so just to brief you, we have the surgery session today, which is being closed. We have a radiology session today, which is closed, and radiation as well, along with you helping us out for driving the sessions on the Hall A. So thank you so much, everyone, from the organizing team, all my colleagues, Palak, Arun, everyone on board. Stay safe, stay blessed. Have a great Sunday, and see you next time.
Thank you. Thank you, everybody.